check, 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 check. Check. Hey.
My name is Karen Anderson, and I survived a type A aortic dissection.
Hi, I'm Andrew. I'm 15, and I'm a survivor.
My name is Deb, and I'm a survivor.
I'm Stacy, and I'm a survivor.
My name is Roger Mallock, and I am a survivor.
Hi, I'm Gemma, and I'm a survivor.
I'm Viv, and I'm a survivor.
I'm Sherry, and I'm a survivor.
Hi, I'm Bob, and I'm a survivor.
My name is Kathy Jo Peterson, and I am a survivor.
My name's Andy, and I'm a survivor.
I'm Deborah, and I'm a survivor.
I'm Stacy, and I'm a survivor.
My name is Sally Ann. I'm 6 months post-op survivor.
My name is Elsa, and I'm a survivor.
My name is Sharon Hilling, and I'm a survivor.
My name is Jessica, and I am a survivor.
I'm Megan, and I'm a survivor.
Hi, my name's Sherry, and I'm a survivor.
My name is Vanessa, and I am a survivor.
Hi, I'm Oleg. I'm a survivor.
My name is Jennifer, and I'm a survivor.
My name is Jolene, and I'm a survivor.
I'm a pre-operative survivor.
I survived.
This is Cam Smith with the Minnesota Vikings, and I'm a survivor.
I'm Pete Johnson, founder of Rock from the Heart, and I'm a survivor.
Am I coming through? Okay, there we are. Good afternoon. Welcome to the Rock from the Heart Aortic Health Symposium. My name is Mike Preston. I'm a survivor, and I'm going to be your MC for today. I'd like to kick things right off by introducing one of our hosts and our first speaker of the day, Amy Johnson. In 2015, Amy's life turned upside down when her husband, Pete, was diagnosed with a rare, life-threatening heart condition. After successful open-heart surgery in 2017, Amy and Pete formed Rock from the Heart, a charity focused on helping people diagnosed with aortic disease. While Amy still operates her telecom consulting company, she now pours her heart and soul into Rock from the Heart. After learning firsthand how incredibly frightening the diagnosis of aortic disease can be, their mission is to help others learn the basics surrounding aortic disease so they can be the best possible advocates for themselves when it comes to making medical decisions. Amy has been giving back since she was a teenager and continues to be an active volunteer in the local community. In addition to her volunteer work with Rock from the Heart, Amy is a board member of the Delano Area Council for Arts and Culture and founded the Delano Community Band. If that wasn't enough to keep her busy, Amy is also a freelance journalist for Herald Journal Publishing. Amy and Pete have 5 adult children in their blended family. They are now empty nesters and live in Delano, Minnesota with their 2 dogs and 2 cats. Please welcome Amy Johnson.
When you're vertically challenged, the microphone never is at the right height. I learned that as a young girl. I'm not going to take much time to sit and introduce myself because we've got such a wonderful panel of speakers today. We want to get right into it. But for me, that survivor video says it all. Before Pete's diagnosis, we'd never heard of aortic aneurysm or aortic stenosis. And boy, we've learned so much since then. And the reason we do Rock from the Heart is what we have right here in this room and those that are watching right now on the live stream from not only across the United States, but across the world. There were people in that video from the United States, from the UK, from the Netherlands, all across the US. So it's really a wonderful thing to be able to connect patients, to connect survivors, to connect caregivers, because when you get diagnosed with this, anyone who knows that first call you get, it's the most terrifying diagnosis, the most terrifying call of your lives. We want to take some of that fear away. We want to take our experience and support others. On that note, we're going to introduce, and you've got her bio, right? So he's going to introduce Karen Anderson, who really is a big reason that Rock from the Heart exists. She was here the first year. We're glad she's here again. So go ahead and introduce
Karen Anderson is the co-founder of the globally recognized post-diagnosis patient advocacy group, Aortic Hope. She's also the president of Think Aorta US. After surviving a type A and residual type B dissection in January 2015, she realized there was something missing from the community. Aortic Hope specializes in providing support to patients and caregivers during their recovery and management with aortic disease. Karen holds her BA in Speech Communications from Towson University and has over 30 years' experience in human resources. Please welcome Karen Anderson.
I didn't think I'd be on a stage. It's very exciting. First of all, thank you so much, Rock from the Heart, members of Rock from the Heart, and Amy and Pete for inviting Aortic Hope to have an opportunity to come out and share with you a little information about our organization. So as mentioned, I am an aortic dissection survivor myself, not a club I thought I would ever be part of, not anything I'd ever heard of, other than a few times in the news with some celebrities who have had this incidents occurred to them. But what happened to me was pretty straightforward as far as dissections are concerned, not as eventful as some other people's stories, but I think what's most important is what happened to me after I had my dissection. And that's what leads us to Aortic Hope. So what happened to me is I realized that when I was in my first clinic visit, my surgeon said to me, "I don't need to see you back now for 6 months, go live your life." I do not know what go live your life means when you still feel like you're half out of it. So what does go live your life mean? I didn't think I'd end up applying for disability and what an arduous task that was going to be. I didn't think I would be having nightmares, smelling things that didn't exist, hearing sounds that didn't exist, crying at a whim, worried every minute of every day that I was going to die if I sneezed or got a cold or walked too fast. I basically was living my life in the beginning on a transport chair, just assuming I would be relegated to a wheelchair because I didn't understand how any of this worked. And I realized early on that if I had met another survivor like me in clinic visit, maybe my recovery would have gone a little bit better, a little bit faster. If I had had some support from therapists, maybe things would have come to light about the PTSD I was enduring. So there was a lot that I realized that didn't exist in the community, and Aortic Hope was born. So I'm going to try this technology. Let's see what I just hit the green button. Is that all I do? Hit the green button. Okay, here we go. So who is Aortic Hope? All of these individuals here are all of our board members, and every one of our board members have been touched by aortic disease. Excluding one person who is our treasurer, everybody has either an aneurysm or has had a dissection or both. So we are individuals who talk the talk and walk the walk in the community. So we're a 501c3 public charity, and as it's mentioned, we were founded by other survivors. And initially what happened is back in 2016, there was a gentleman from Sweden who, with some members of the United States, decided that September 19th would be Aortic Dissection Awareness Day. And I talked with my local hospital, and I thought, well, why don't we pull together some people in the community, let's all meet up. This was, of course, pre-COVID, when you would meet up together. And we did so, and I met another survivor who came from Pittsburgh. She had had a 7-centimeter aneurysm that she was able to have scheduled and have surgery on. And I met a third woman who was a provider, a caregiver, to her husband at the time who had Marfan syndrome, and their eldest daughter who also had Marfan. So here it is, 3 women, one's a caregiver, one had an aneurysm, and myself who's a dissection survivor. And we decided to put together a Facebook page called Aortic Hope. And it was supposed to just be inspirational quotes. And very quickly, that changed. So some of the goals of Aortic Hope is to spread hope, to create awareness, and provide support. And we do that in a variety of ways. This is so fun looking at this from an angle. I don't have it in front of me to read. So yeah, so spreading hope is the cornerstone of what we're about. And we do that, initially we were doing all of that through Facebook, and we post a lot of inspirational quotes and a lot of stories that survivors share with us. We then started what was called a survivor series, and it has really, really grown. And people can submit to us their stories via a blog or via a video or even dare go live on our YouTube channel and share their stories of inspiration. And what we have found is other survivors hearing stories, it validates their experience, it validates them emotionally, it provides thought-provoking questions that they can take back to their own physicians when they hear the little subtle nuances in someone else's story. We also started off our first initiative with something called Hope Mail. I saw a member in the community that was having surgery fairly quickly into us becoming aortic hope. And so I knitted her a little heart-shaped pillow. And that turned into about 15 or 18 people wanting pillows. And real quickly, my hands were starting to hurt. So before we became a nonprofit, we did a GoFundMe. And we ordered some items, and kind of Hope Mail was born. And what Hope Mail is it's free for the public. You can sign up, and once a year during your designated aortiversary month, we send everybody a small token of acknowledgement that we're here for you, we see you, we hear you, and we're cheering you on. Okay. And there's an idea of what some of the Hope Mail care packages look like. Every year they're different. Every year we try to come up with some products and items that we think will be helpful during their journey of recovery of this disease and management of the disease. So that can be stress balls, it's journals, magnifying bookmarks, pill cases, just a variety of items that we think people will find exciting and interesting when they get their little package in the mail. And again, the Survivor series, it's also told from the caregiver's perspective or the survivor's perspective. And interestingly enough, what we have found is there's also a very important place for individuals who are grieving the loss of a loved one as well. So we do share those stories too, because they're important to hear. We can all learn a lesson if there's been a misdiagnosis or an unfortunate repercussion to having an aortic dissection or some surgical experience. And we create awareness too. Most of our awareness is to help other individuals find us so they can start receiving the same support that, that most of you in the room are receiving from Aortic Hope now. But we do this by participating in a variety of things, whether it's a radio show, a television show, speaking engagements, speaking to the Rotary. We have gone to nursing schools. We've given our symptoms and wait to see if they can figure out what's wrong with us. So there's a variety of ways that we can create awareness within the community. And we provide support. And support changes day to day. It looks different every single day. It looks different for me every single day. It looks different for my board every single day. So when we provide support to others, we in ourselves are also receiving support. And we host live Q&A sessions. We used to do them on Facebook, now we're doing them through YouTube. So I have an opportunity to talk to different professionals, whether they're surgeons, whether they're attorneys, talking about the disability process and how hard that can be. And I give the public an opportunity to ask questions live and have them answered. We also have Ask a Doctor event, and that happens on Facebook, where doctors are present and they will take your questions live and put the answers right up on Facebook for you to see. I think one of the most interesting things that we do that sets us apart is we have twice a month support group meetings. So we offer support group meetings in a closed setting through Microsoft Teams. That's for our patients and our survivors. New for 22, we offer them for caregivers as well. Twice a month, private, for caregivers only. And we're also going to be implementing in March, having once a quarter for individuals that are grieving the loss of a loved one. Tableside patient advocacy cards, which they may be in your folders, are basically informational cards that can be set up in a doctor's office in the waiting room and also presented to the patients when they're in clinic. And this really helps the patients find out where they can start receiving support immediately. These things are distributed, by the way, by people that volunteer for us all across the country. They're called Hope Ambassadors. This talks a little bit about the Q&A sessions. Not only have I interviewed thoracic surgeons, cardiologists, attorneys and partners of disability law firms, I've also interviewed therapists who have explained in great detail EMDR therapy, which helps PTSD. I've also done a sound bath online with someone who is a massage therapist who specializes in grounding techniques, going through the 5 senses, listening to sound, smelling different smells, different ways to help ground us and reduce the stress that's in our life. And again, one of the cornerstones of our organization is providing these support group meetings. There's another organization that's called Aortic Bridge, and we have formed a nice afternoon group with them as well. So what we're finding is community collaboration works, having a partnership helps, And doing that in the forum of a support group is really, it's very special. We do have people that sit in and give presentations on occasion and have guests. But what is so special about these support group meetings is they are not being run by a therapist or a social worker. They are being run by survivors. And I think that that's appreciated greatly. And this is an example of what the patient advocacy cards look like. This was fun, walking into a doctor's office and seeing it sitting there on the table. There's nothing better than knowing that other people out there that may not be on Facebook have an opportunity to hear about aortocope and start receiving support. So on Facebook alone, we're at about over 4,000 people that are participating with aortocope. This does not include how many people that we have not been able to capture statistically yet that we're finding following us on YouTube, but we are represented in, I believe, over 49 countries. And that goes over different ways that you can get in touch with us, which should be on those advocacy cards. And I do want to talk a little bit about another organization that I am president over and work with and collaborate, and that's Think Aorta US. So what we've realized in the community is there tends to be 3 different avenues that these organizations fall under. There are individuals that are pre-active, groups that are proactive, and groups that are reactive. And we consider aortocope to be very reactive. We're the catcher's mitt. Once you've had your diagnosis, whether it's an aneurysm, whether it's a dissection, caregiver, or you've lost someone, we're the catcher's mitt that comes in and says, where are you? Where can we meet you with this? Because it tends to be like the tide. Some days are good, some days are not so good. And we kind of looked at 2022 and we said, how can we have a community collaboration? Well, Think Aorta was started in the UK and Ireland as a campaign by another similar patient advocacy organization to aortocope. And the goal has 2 main buckets, one being to help educate medical professionals on the importance of thinking aorta, thinking about it right from the start, and helping to train the smaller regional hospitals to think about it sooner and refer the patients to the receiving hospitals. The other bucket is to empower the patients to start thinking about their medical history. Hence, hashtag Think Aorta, Think Family was born. If we start talking about the medical history that we have and what our parents or our grandparents have, we realize there's a genetic component to aortic disease. If we can share that information with our providers, maybe they'll realize it sooner too. So Think Aorta is very pre-active, and we've brought that campaign to the United States, and now it is its own nonprofit. And what we have found with Rock from the Heart is that they're very proactive, and they do their proactive work in such a unique, interesting way. They're able to pull people together for events like this and educate everybody and do it around music, which is so exciting. It's so wonderful. Everybody's happy when it comes to music, right? So when you have a pre-active, proactive, and reactive organizations coming together, that's community collaboration, and that's going to make a lot of changes in the world. Does anybody have any questions or anything? We'll save it for Q&A. Thank you so much. Thank you.
Thank you, Karen. Just a couple quick blurbs here. Don't forget to follow Rock from the Heart on social media, on Facebook, Twitter, LinkedIn, Instagram at Rock from the Heart. Also remember to check out the silent auction items. There are 32 auctions. You can scan the links that are at your table there and bid on the items. And there are still great seats available for tomorrow's Grand Funk Railroad concert, so don't forget that. Okay, I'm going to introduce our next speaker. Dr. Santiago Garcia is a staff interventional cardiologist and director of the TAVR and Adult Congenital Structural Program at the Minneapolis Heart Institute. Areas of interest include minimally invasive transcatheter valve replacement and repair, clinical trials and structural interventions for adults with congenital heart disease. Dr. Garcia received his medical degree from the University of Buenos Aires in Argentina. He trained in internal medicine at the University of Miami and then completed a fellowship in cardiovascular medicine and interventional cardiology at the University of Minnesota. Please welcome Dr. Santiago Garcia.
Thank you very much for that kind introduction. It's my pleasure to be here with all of you today. So I'll be talking about the aortic valve and how in my view, this treatment, TAVR or transcatheter aortic valve replacement, has revolutionized the space and the way we not only treat patients but also approach the disease. This is, let me try to advance the slides here. If you can play that video. So this is a moment in medicine that all of us will remember who are involved in this. And you can see this is the first case of TAVR performed in France. And the important component of this picture is not so much the doctor, is the patient. And what you notice here is that the patient is extubated. There is no tube in his mouth, and he's looking at the camera. This is only a few minutes after this procedure was performed. And what has enabled us to do these procedures this way, in a minimal invasive way, is that we don't have to open the chest anymore to replace the valve. Now, if you had told me in medical school that I was going to be doing these procedures from the groin, I would have said, you're crazy, that's not possible. The valves are going to embolize, they're going to go somewhere, you're going to block the coronary arteries, the patients are going to have heart attacks on the table, and it's not going to work. Well, somehow we managed to do that through medical innovation, and you can see how these valves are Crimpton balloons, so they have a very, very small profile, so we can advance them through the groin, and then we can deploy them by inflating a balloon and expanding that stent frame so that we don't have to remove the diseased valve. And Dr. Stephan will give you his perspective on how we do this surgically. But the surgeons, when they open the chest, they remove the diseased valve and they put a new one in. With this procedure, we don't do that. We push the old one to the side, and the new one takes over. We're now 20 years into this journey of TAVR, and I thought that for this lecture, I was going to tell you what's going on in the space now in 2022. So what are the achievements, what are the struggles, and where are we going as a community? So I have, I think, 25 minutes. First, I'm going to talk about the expansions of indications. So first, this procedure was designed for patients that were unfit for surgery. And so these are very, very old patients who were deemed by a surgeon and by a cardiologist to be a prohibited risk for surgery because most of them were not fit enough to tolerate that kind of procedure. But in the last 10 years, this technology has expanded to the overwhelming majority of patients with aortic stenosis. So I'm going to go through that journey. We're also challenging ourselves. Our paradigm was we are not going to replace the valve until patients have severe disease by echo, but also symptoms. And you can say, well, that seems simple enough to follow, but the reality in clinic is that many of these patients come to us walking with a cane in a wheelchair, and being able to elicit symptoms is not an easy task. So we're challenging the paradigm. Do we need to pull the trigger for intervention early when we look at the echo before symptoms happen? Because that valve is not opening well. Why are we going to wait for symptoms? And the third one is the improvement of complications. This procedure is pretty good. I would say what I tell my patients is the risk of bad things happening is in the low single digits, 1 or 2% of things that we don't want to see, mortality, stroke, etc. But there are some issues that still occur, like needing a pacemaker. That happens in about 10% of patients. And I'll show you some of the things that we're trying to improve so that it happens in ideally less than 5, which is what surgeons can accomplish. So this is what happens today in the United States. So the overwhelming majority of patients who need surgery, who need an aortic valve replacement, are considered low risk for this operation. So the bar is actually quite high for us because we initially were competing with a technology that has been around for 50 years. And these patients are younger, they have fewer comorbidities, and they can actually have surgery and do well, and many still do. They have excellent outcomes, and because they are young, many will actually outlive their valves. So these valves that we are putting in today in most patients are what we call biological or tissue valves. And because they're made out of animal tissue, they will not last forever. The expectation is that most of these valves will last 10 years, give or take. So that we have to keep that in mind as we are moving towards patients that are younger, because what are we going to do when the valve fails? And so this field of TAVR in TAVR is now being considered as an option for patients. But these are conversations that we have with all our patients that need a valve replacement, not just what's going to happen in the next month, but what's going to happen in the next 10 years. Many of these patients, about 20% of patients, still need mechanical valves. The advantage of these valves that don't degenerate because they're not made out of biological tissue. The big disadvantage is that they need to be treated with blood thinners indefinitely. And that's a proposition that for many patients is not acceptable because they don't want to take blood thinners for the rest of their lives. So with those considerations in mind, we had to prove that this technology, TAVR, was as good as surgery. And I think we met that bar. There was 2 trials sponsored by the 2 valves that have received commercial approval in the United States, and you can see the results here for the things that matter, death, stroke, and rehospitalization for heart failure. At 1 year, TAVR was not inferior to surgery. In fact, it was better than surgery, in particular when it comes to rehospitalizations. The same was shown for the other valve, similar rates of mortality and stroke with less patients coming back to the hospital after the index procedure, which is a good thing. So this led to a significant expansion in the indication for these procedures, and you can see now this is what's happening in the United States. On the right, you can see the number of TAVR procedures, and you can see that in the last 10 years, the growth has been exponential. The other 2 lines that you see is the number of surgical procedures. One is with bypass, the other is without bypass. Now, the number of TAVR procedures exceeds the number of surgeries. Over 70,000 procedures are performed every year in this country. And you can see on the left side, the procedures are being performed on patients that are lower risk. So it's important because these patients are actually going to live 10, 15 years, and we need to, as we're fixing one problem, we're probably creating another one, which is how do we treat these patients in 10, 15 years after they have a successful TAVR procedure. So more to come on that. Now, can everyone be treated with TAVR? I would be lying to you if I say yes. Not everyone has the right anatomy for this procedure. I would say the overwhelming majority of these patients have the right anatomy, but we have to look at the CAT scan. We do a CAT scan that is very useful for us to decide what to do. We're talking about aortic disease. Many of these patients have bicuspid anatomies, and those cases can be really challenging for us to treat. There are patients that have, as shown here, a nodule of calcium that, as you can imagine, can prevent expansion of the transcatheter valve, or if you are successful in expanding this, it can create problems. It can rupture the aorta, it can rupture the heart, etc. There are other companies that are trying to get into this space and design valves that could potentially treat all these patients. And this is a valve from Boston that was in the market for a number of years now, has been withdrawn from the market, but it was used for this particular subset of patients that have nodular calcium because it had no risk of rupture. It's not deployed by a balloon, it's a self-expanding valve, and it could be recaptured and redeployed many times. And it worked really well for these patients that have calcium below the valve. And so there are always iterations of technology and trying to expand this indication. This is another one that hopefully will be available in the US in 2 years. It's a self-expanding valve that, as you can see, has big holes on the top, and those are designed so that you can actually access the coronary arteries. If you put these valves in patients that are young, that may have a heart attack or need a stent later on, you need to put a stent. You need to be able to do that. So these technologies are now being designed with those considerations in mind. So not only that you want to fix the problem, but also you want to avoid blocking the coronaries and creating other problems where they're not needed. And as you can see, this valve is deployed relatively straightforward way, and what we're looking here is we don't want to see any contrast, any leaks of contrast back into the heart. So the valve is competent and is working well. Hopefully there will be a third valve available in the market in a couple of years. Continuing the same line, indications expansion. So we're challenging ourselves and saying, why are we waiting for patients to have symptoms? Can we intervene early? So now there are 2 trials looking at early intervention. This is patients that have severe disease but no symptoms yet. And they are being randomized in a 1-to-1 fashion to standard of care, which is you come to the doctor office every 6 months, meet someone and who will ask you about your symptoms, and if the answer is no symptoms, then you can come into the office annually, versus I see enough on the echo, I'm going to pull the trigger and replace your valve now. And why are we challenging ourselves? Because we have a technology where we can do this procedure from the groin, the patient goes home the next day, and the risk of the procedure is very low. It's not more than 1 or 2%. So it sort of makes sense to intervene early. We have completed enrollment in this trial. It's called Early TAVR, and hopefully we will have results next year after the 1-year follow-up is complete. So this may completely change how we approach this disease. Now, what are the challenges that we still have? Well, stroke is one of them. In particular, in the first 5 years of experience with TAVR, the devices were kind of bulky. And as you can see, there is calcium not just on the aortic valve, there is calcium on the aorta, and you need to get there with catheters, so that could potentially break loose and migrate north and give you a stroke. The risk of a stroke in contemporary practice is fairly low. It's about 1 or 2%, but we want the number to be 0. So one of the things that we're testing now in another big trial with over 3,000 patients is the use of this protection device, where you essentially position filters. If you don't mind playing the video, you can advance this device from the wrist and position it in the vessels that feed the brain, so that if there is any debris that wants to go north, you can capture it before it gets to the brain. And the idea here is that you could potentially prevent most strokes by doing this. It takes a few minutes to put in, and it's done before the valve replacement. So that the expectation is, yes, if there's going to be debris going to the brain, they will be captured before they do damage. So this is the kind of stuff we're capturing the filters. You can see that these are big chunks of calcium and tissue, et cetera, that could migrate to the brain and cause problems. So the idea is to go from the 1 or 2% of patients that have clinical relevant strokes to 0, because we want to have that number. The data, preliminary data, looks pretty good, but again, we need more than just a few hundred patients, and hopefully we'll get an answer in the next 6 months. The trial is complete, over 3,000 patients enrolled, and that will give us a good sense for whether this technology works or not. Another issue that we have with these valves, which actually happens also with surgical valves, is the development of small, tiny clots on the leaflets. And this is something that we can see on CAT scans. There was a lot of noise early on in the experience, and some patients had strokes, others have congestive heart failure, and whatnot. And you can imagine that these stents sometimes cannot fully expand because of the amount of calcium on these valves. And that's something that we're trying to understand what this signal means. Is this just an imaging finding, or is this something that needs to be addressed and needs to be treated? Again, this affects approximately 10% of patients if you do CAT scans at 30 days after this procedure. There have been trials looking at blood thinners as a way to mitigate this. It's very effective in resolving the imaging finding, but yet they actually worsen mortality. So we don't routinely use blood thinners after this procedure. When you do scans 30 days and 1 year, many of these little clots disappear by themselves. So we still don't know what this means. We have data from our own center that is going to come out soon, hopefully, showing that there is a signal in favor of mortality for patients that have those little clots if you follow them for long enough. This more to come here. We need to understand the signal and what it means and what could be done to mitigate this. Finally, the third issue, which I think is relevant for this procedure, is the potential need for a pacemaker. And this is what I tell my patients. Most of the complications that we fear are in the low single digits. The other one that is in double digits is the potential need for pacemaker. And this relates to the proximity of the aortic valve to the conduction system of the heart. So you can see this is a pathological specimen where we would typically position the valve is just a few centimeters north from where the electrical conduction system is. And so think about a cable that connects the top and the lower chamber of the heart that is traveling right next to the valve that you're trying to fix. When you expand this new transcatheter valve, you can damage that structure. And that means that the top and the lower chambers of the heart are not working in sync, and the patient may need a pacemaker. In addition to that, we have made attempts in all these valves to mitigate leaks around them. So we put tissue in the bottom of the stents that you can see here, tissue wraps or skirts, to try to mitigate these paravalvular leaks or PVLs. So that's the stuff that also can have an effect on the conduction system of the heart. So that if you look at the rates of pacemaker, they have been fairly constant over the last decade or so. It's about 10 to 15%. And this is something that I think the surgeons have much lower numbers than we do, to be honest. It's no more than 5% or so. So what are the things that we could do to mitigate this problem is to try to deploy these valves as high as possible so that we don't interfere with the conduction system of the heart. So in our early experience on top, it was more of what we call 50-50. So 50% of the stent will be in the aorta, 50% of the stent will be in the heart. And now we learn that it leads to almost 1 in 5 patients needing a pacemaker. So if we deploy the valve higher, more in a 90-10 position, the number can go to single digits. And that has been shown by this group and others. So modifications in the implantation technique are also important to try to mitigate this complication. So I don't want you thinking that complications are an issue. These are some of the things we're working on. The procedure, if you can play the video, is, I think, 99% of what it needs to be. This is Mick Jagger. If you can open the link. 6 weeks after he started the procedure. Hopefully you can see him, because he's the best advertising I can think of. 90+% of patients go home the next day. And the patients that don't go home the next day is because they need a pacemaker. They go home 48 hours typically. But this is the beauty of this procedure. And
the rock legend tweeting the video out today, just 6 weeks after his treatment. Tonight, Mick Jagger, perhaps signaling, "Start me up."
No. Thank you very much for your
Billboard
attention.
has reported the Rolling Stones may now kick off their delayed tour as early as July. Whenever Mick Jagger returns, be ready. 6 weeks after treatment, he's better than the rest of us.
Amy, should we do
Right
questions
back
now?
here tomorrow. Until then, good night.
Hi everyone, George Stephanopoulos here. Thanks for checking out the ABC News YouTube channel. If you'd like to get more videos, show highlights, and watch live event coverage, click on...
All right, well, thanks again for having me.
Okay, our next speaker, Dr. Christina Finola, is a cardiologist and vascular medicine specialist at University of Minnesota Heart Health Care. Dr. Finola received both her bachelor's and medical degrees at George Washington University in Washington, D.C. She completed her internal medicine residency and vascular medicine fellowship at Boston University. She also received her Master's of Science in Epidemiology at Boston University School of Public Health. She went on to complete her fellowship in cardiology at Boston University. Dr. Finola is board certified in internal medicine, vascular medicine, and vascular ultrasound. She has an interest in the management of complex aortic and venous diseases and the use of ultrasound in cardiac and vascular critical care. Please welcome Dr. Christina Finola.
Well, thank you very much. Can everyone hear me okay? Is the microphone close enough here? Okay. So it's such an honor to be invited to this and to see several of my patients right now in the audience. I have a little bit of a unique spin on aortic disease. I'm kind of the investigator, you know, after a dissection, after someone is diagnosed. I take about 10 steps back and say, why? You know, why is this happening to you? And I look at it, you know, in kind of a precision medicine-based approach to aortic disease. So I'll go through a little bit about how I run my practice, and hopefully you'll take some things home from this today. I just have a few disclosures. I am on the 2022 American Heart Association and American College of Cardiology Aortic Guidelines Writing Committee, We are in the middle of publishing a new document, which will be out in about 6 months. Unfortunately, it's embargoed. I'm not allowed to share our updated guidelines, but I will happily share it with all of you when it's published. So, I'm going to have to stand this way a little bit. Okay. So, I like to go through the causes here. There's a lot of causes of an aortic aneurysm. So, 80, 90-year-old with hypertension, potentially it's degenerative. I do a inflammatory aortitis clinic as well, so these are more rare large vessel vasculitis type situations, Takayasu's or giant cell arteritis. There are infections that cause aneurysms like tuberculosis and syphilis. Traumatic and motor vehicle accidents can enlarge the aorta. And I also see a lot of athletes in my clinic. We can see mild dilation over time in the endurance athletes. I do focus mostly on genetic in my clinic, and so these include syndromic, like Marfan syndrome, Loeys-Dietz, and Ehlers-Danlos. I look at familial types, Turner's syndrome, and then the bicuspid aortopathies. So the aorta has a lot of different parts to it, especially the root that we look at. I like to look at the anatomy and imaging, what part of the aorta is actually involved, and can we actually tell the etiology or the cause of the aneurysm based on just looking at these different components. And aortic enlargement is not just one part of the aorta. There's all these different unique areas that we look at in imaging, and we decide maybe this is cluing us into why it's dilated. So when you see an echocardiogram report, you actually see these 4 things listed on your report. There's always a measurement for these 4 components. And again, each one kind of tells a story about what's going on with the aorta and the aorta root. I do a lot of echocardiography in my clinic, and so a lot of you like to look at your echoes as you're getting them scanned. This is a really great view in how we look at it in the echo lab, and we measure it. Unfortunately, it's 2-dimensional, so you can see there's probably a lot of artifact within an echocardiogram in measuring. That's why a lot of these we use as screening, and then if it's abnormal, we like to follow up with 3-dimensional imaging. We can look at the arch by echo. So after the root and the proximal or the first part of the tubular part, we can go march down the arch with echo and actually look at the part where it starts to descend above the diaphragm. We look at the aortic valve, and so it's really hard to see. It looks like a little alien there. I'm sure it's hard to decipher without video, but we look at the heartbeat through the aortic valve. We can tell if it's bicuspid or not, usually by transthoracic echo. There are some caveats to it, of course. And then we look at the abdominal. They've ever stuck, with the probe under the ribs, we can actually look at the abdominal aorta and get a sense of how flow is getting to that abdominal part and if that's also enlarged as well. So it's really confusing. What's dilated, what's not? As an echocardiographer, this is from the American Society of Echocardiography, their guidelines. So I take an age plus a body surface area approach, and we are correcting these guidelines a little bit upcoming this year. But for the most part, you take your age, you take your height, your body surface area, and you have what's normal for you in these boxes. And then we can actually see how dilated or how not dilated is your aorta based on these groupings right here. So, and we do that using standard deviations outside of this norm. Some of you have probably heard about a Z-score. We use this in the younger population as people are starting to grow and they're still in their early ages and maybe their height's not at the maximum height that they're going to be as an adult. A Z-score can be helpful and account for that age. And so we actually have a Z-score interpretation online. There's calculators. So a Z-score is helpful when I say I have a 20-year-old. I know they're probably still going to grow for the next decade. We can compare Z-score to Z-score over time, and that can be useful. So I'm going to march through a couple genetic syndromes. This is really to gain awareness. What are the syndromes out there? what are the associated findings if you do have an aortic aneurysm, what else can actually happen with these aneurysms. So we think about the aorta and the aortic wall layers, 3 layers. A lot of the genetic syndromes or hereditary types come from breakdown of smooth muscle cells, your elastin and your collagen. All the genes that that synthesize collagen tend to be creating this disarray of that layer, and that can cause the aneurysm. So going through Marfan syndrome, so this is most common connective tissue disorder that we know. It's autosomal dominant, which I'm going to talk about a little bit. That means 50% in your offspring. So if you have a carrier of a gene, that gene is going to be carried into about 50% of the next generation, so on and so forth. And so it's a mutation where you have elastic fibers that can be fragmented and causing some altered matrix of the aortic wall. Here's just imaging clues that we look at. We have actual criteria, major and minor, for Marfan syndrome. So again, I look at the echo and I look at the various parts of the aorta and the mitral valve. It can affect the pulmonary artery, and we can piece together the likelihood of Marfan's based on imaging. And here's just an example. You get a really dilated root near the aortic valve in Marfan's. You can get a dilated pulmonary artery, and then you can get mitral valve prolapse. So you always want to look at the mitral valve when you have a diagnosis of an aneurysm. So patients have, they're tall, elongated arm spans, dental crowding, high arch palate, joint laxity, chest deformities, lens dislocation's a big thing. So I go through all of this in review of systems. And there's something just called GINT criteria for Marfan syndrome. It takes into account the phenotypic features and also genetics and imaging. Loeys-Dietz syndrome is also a genetic syndrome that causes aortic dilation. And there's a lot of different genes for this, and we have some 6 subtypes that we can test for. With Loeys-Dietz, there's bifid uvula, which is a uvula in the back of the throat, split in half, a high arched palate, eyes wide, set apart. The problem here is there is vascular fragility in Loeys-Dietz. You may not actually have an aortic dilation before getting an aortic dissection. So this is really important diagnosis to pick up front. There can be a root aneurysm like Marfan's, but 53% do not have the root involved, so it can affect other vessels, coronaries, the head and neck, pulmonary, and there can be other associated structural heart defects, including bicuspid valve as well. Ehlers-Danlos syndrome, this is a connective tissue disorder characterized by abnormalities in the skin, visceral organs, and blood vessels. Can affect really any blood vessel in the body. Again, a collagen synthesis gene mutation. Up to 25 can have aortic aneurysm disease. Age can be, I pick up Ehlers-Danlos as early as 20. I've had a 75-year-old that I've diagnosed. A lot of them have hypermobile joints, classic type especially. Vascular type does not have to have hypermobile joints, however. So, and this is the more rare type, less than 5% of the cases. And you can see how many different types of Ehlers-Danlos there are. This is from 2017. And with vascular EDS, there's a specific gene that's pretty sensitive for it, the COL3A1 gene that we can test for, and that's specific to the vascular type. And we can diagnose patients like this. We do sort of a phenotypic assessment and see if they fit this criteria. We do, of course, want to know this as well. There is vascular fragility associated with vascular Ehlers-Danlos. We'd like to know that preoperatively going into something where we're going to do catheter-based procedures. We really like to nail down this diagnosis and make the right preventive measures for these patients. And bicuspid aortopathy and coarctation of the aorta. So bicuspid is a common prevalence pretty much. 50% have a root or ascending aortic dilation, and less so a coarctation, which is a pinching of the descending aorta. So the dissection risk is increased compared to a normal tricuspid valve, and I'll go into that. And sometimes coronary anomalies can exist. So you see on the left what bicuspid valve looks like, normal versus bicuspid. There's a fusion of 2 of those leaves, and just it opens up and causes eccentric flow. Coarctation on the right, it's a pinching right after that arch. You can have various types. There's 4 subtypes there. With bicuspid aortopathy, so you can see on the left, basically the bulging can be very early on after the valve, or it can be later closer to the arch, and I'll go into why that is. And you also get sort of a destructive smooth muscle cell loss and also loss of collagen as well. I show all my patients this picture. I think this is so telling with bicuspid aortic valve, why some people get dilated and some people do not. This is 4-dimensional MR angiogram flow. I think this is an extremely important article that came out. The first one on the left is normal. You see all the blood flow is in the red. That's where all your blood flow in a heartbeat is pumping out. It's right in the middle of the vessel. It's not banging against the walls. The second one is a right and left fusion bicuspid valve. You can see the way that the jet of blood flow is going. It's hammering on that one area and swirling around. Over time, that's going to dilate that aorta right there. But the third one, this is a right and non-fusion. You can see that, yes, there's flow that's on the side of the wall, but it's not actually swirling around and causing as much dilation. So with bicuspid valve, you might not get a really large aneurysm, but the risk of dissection might still be there. So it's really important to look at the type of fusion, look at 3-dimensional flow, and really understand the dynamics of these patients' blood flow. And bicuspid valve, like I said, is kind of easy to pick up on echo if you get a good image. We can do all the survey of the aorta there. Coarctation, we usually do CT angiogram imaging or MR angiogram. We look at the pinching of the downflow aorta there. So there's a lot of other associations with congenital heart disease, so sometimes if I pick this up, I will also do a full cardiac MRI to look for other congenital valve or septal defects. You can see coarctation on the aorta. It's not extremely sensitive, but we can get a clue, and then we would follow it up with CT or MRI. And clinical features of coarctation. So if you have a bicuspid valve, you should always be screened for coarctation, especially if you have long-standing hypertension, if you have any signs of poor blood flow. Basically, it's pinching off blood flow down to the rest of the body, so you can get pain in the body, you can get pain in the abdomen or down to the hips or the legs even. You can get diminished pulses, so it's important to screen for that. Coarctations can be easy to repair. We have both endovascular and surgical approaches, and there's ways to measure that gradient through a catheter to decide if it's necessary to repair or not. And the last group that I'll talk about is just familial types. So I see a lot of these. So again, autosomal dominant. Familial types we see a lot in every generation. 50% can carry a mutation. So the ones that I see that were most described in literature, ACTA2 mutations, the TGF-BR2, and MYH11. But we're seeing a lot of new genes come out that we still think are familial types that we're starting to write up about. So suspect familial types if you're young, there's sudden cardiac death in the family, unexplained heart attacks with no autopsy, and then multiple aneurysms in family members. And then you don't fit necessarily other features of the syndromes. So this is a case study, for example, that looked at these 3 familial type mutations, case series that was published. So one patient had the MYH11, it had a dissection at 4.5, the TGF1, multiple dissections documented less than 5, and then the ACTA2 less than 5. So why is this important? Well, our next guidelines coming out, you know, we're no longer getting to a absolute diameter of 5 to 5.5 for everybody. We need to take into account family and genetics, and how does that actually help our management. Here's just a summary of imaging guidelines for the various syndromes. Everyone usually gets 3D imaging. Most people, once they have an aneurysm, we do annual screening. Usually after the first diagnosis, I like to do a 6-month scan just to document growth. And then after repair, of course, usually it eventually goes to 6 months to annual screening as well, or surveillance. So screening first-degree relatives, bicuspid aortic valve, premature onset of thoracic aorta disease with minimal risk factors, or any type of familial form of thoracic aortic aneurysm. So I try to make good recommendations on who to get screened and at what decade should they start screening. So we offer a panel of gene sequencing. There's about 35 aortic genes that we have from Ambry Genetics. Insurance covers most of it, and the company actually picks up a lot of it as well. So it's a low out-of-pocket cost for patients. It's not helpful in everyone. We don't do it for everyone, but it can be helpful in large families with a lot of kids and grandkids. If we discover one of these mutant genes on the right, then first-degree relatives can undergo screening for that exact gene and find out who needs to have sort of that long-term surveillance imaging. A lot of my patients have a variant of undetermined significance. Now, what is that? That's an associated, it's associated with these mutant genes, but may not be the exact location of the original gene. I still think it means something. Sometimes family members will test for that variant, and it can help in certain circumstances. And then surgical guidance, again, this is gonna change soon, but Marfan syndrome, usually repair at 5 centimeters, or if there's rapid growth or a family history of a lot of dissections. Vascular EDS is really independent, case-by-case basis because of their higher vascular fragility during surgery. Louise Dietz, actually lower diameter, they tend to dissect earlier, so we say even 4 to 4.5. Familial types are really based case-by-case basis for sure. And then bicuspid, we are recommending, if there's valve disease, 4.5. If there's no valvular disease with it, no regurgitation or stenosis, then usually 5 is our cutoff to start thinking about elective repair. And degenerative old person who is low risk, potentially 5.5, or if there's growth. And then best practice for my recommendations, figure out the aortopathy first, and then you figure out the surgical plan. So this is Fanola's Guide to Medical Therapy in Aortic Disease. This is very general. So antihypertensives, if I can squeeze losartan on people, I will, and beta blocker, that really helps that anti-impulse therapy that bangs on the aorta. Antiplatelet agents, if there's concomitant plaques or cholesterol in any of the vasculature, or if there's peripheral artery disease, coronary disease, then we consider an antiplatelet agent. Cholesterol management, if there's high cholesterol, statins might. There's some data to suggest that statins could reduce growth due to its anti-inflammatory properties. A good diet, Mediterranean diet, and for vasculitis patients, we do steroids and kind of the big gun medications to prevent inflammatory growth. So exercise and lifting guidance, avoiding Valsalva. Valsalva just means you're really bearing down, like you're having a bowel movement, that straining of where you're contracting your abdominal muscles, that shoots up your central blood pressure. Some people who are athletes and my really active patients, I'll actually bring them into my stress lab who have either post-op dissection or an aneurysm that's mild. I won't push them to the limit, but I'll say, do what you normally do for your favorite exercise. We'll see what your blood pressure's doing. If it's skyrocketing, we know we have to be more aggressive and actually give even temporary blood pressure meds during their exercise. Stress management's really important, pre and post-operative, yoga, meditation. It is okay to exercise, moderate intensity, avoiding high intensity interval training. Post-surgical, we try to get everybody into cardiac rehab programs. They've been doing an amazing job for our aortic patients. So again, the document will come out that will go into specifics about all of these categories. And I want to just give special thanks to my patients. This is a unique disease. Again, awareness is critical. Since I've started my clinic, I now inherit family members and children and nephews and cousins. It's really meaningful to just prevent these events from happening by getting them established early into clinic. And I will apologize that I have to leave. So who knows Jessie Diggins from the Olympics? Anybody? I am skiing the American Birkebeiner tomorrow. It's 50 kilometers. I'm as crazy as her, so I'll be heading off to do that today. So that's my little special interest on the side. But it was a pleasure to be here, and thank you. And here's my email. Reach out to me anytime with questions, concerns. I'm happy to talk to any of you. So thank you very much.
Thank you, Doctor. A couple quick announcements. Don't forget to log on to the Huva app leave feedback, and be sure to fill out the session and event surveys on this event. Also, if you'd like to know more about Rock from the Heart, check out the website, rockfromtheheart.org. All right, our next speaker was named 2021's Top Doctor Rising by Minneapolis St. Paul Magazine. Please welcome Dr. Robert Steffen.
Hey, good afternoon, and thank you very much to the organizing committee for giving me the invite. I really appreciate it. So, I'm really the guy nobody wants to hear from. You've met with your cardiologist. They've told you you can't survey this anymore. The imaging has gotten worse or it's severe. You've met with Dr. Garcia. He's taken a look at all of his transcatheter options through the groin, through the shoulder, through the neck, and he thinks that there's nothing that he can do for you. So they send you to me. So I talked to Amy earlier, and she said there were a couple things that she thought were interesting. Questions that were pretty typical. So I went over I'll go over those, and if you guys have anything else you want to hear about, please feel free to let me know. There we go. So 4 major topics I'll talk about this afternoon. What does recovery from open heart surgery mean? When people hear open heart surgery, they think of just a really big undertaking. So I'll go into a little bit more of the specifics of what it looks like to recover from open heart surgery. When is valve repair an option? When we can't repair the valve and we have to replace the valve, what options do we have to replace it? And then if we're going to replace the valve, what valve should we use? Okay, so probably the most 2 common questions I get when I tell people they're going to have surgery is, are you going to break the ribs? And is this going to be really painful? And the answer to both of those questions is no. First, I'll talk about the incision. We don't almost ever break any ribs. There's a bone that goes, is it the green button here that we're supposed to hit? Green button, okay. Can you go back 1 slide? Sorry. There we go. So there's a bone that runs down the middle of your chest called the sternum, and so the ribs come from each side and they attach on that bone. So we usually cut either the entire bone on the left, which is called it's called the sternum. That's the bone, the sternum. So we either cut the entire bone, we'll cut part of the bone, or sometimes we leave that alone and we'll do what's called a thoracotomy. So we'll go between the ribs, but we never break any ribs, which is actually important because all the neurons and the sensors come from your spine all the way around the side, and they run right on the ribs. So breaking ribs is very painful. The sternum, which is a rigid structure as far away from those nerves as you can possibly get, actually isn't very painful. So we cut it, we put it back together. It's not mobile, so you don't really feel it going around like if you've ever had abdominal surgery. The muscles move, it pulls on the sutures, that hurts. The sternum is fixed, it's poorly innervated, and really does not hurt very much. So do we break the ribs? No. Is this going to be really painful? No. Is it going to wipe you out for a while? You're going to be pretty tired? Yes. But not going to break the ribs, not going to be super painful. So everybody needs their guy. Santiago got Mick Jagger. He did great. But you can also do great with open heart surgery. So that's Arnold Schwarzenegger on the right. He's had it a couple times, has done really well. The guy on the left, maybe not as comfortable as the guy 15 minutes after his TAVR, but this may be the next day, 2 days, 3 days after surgery. People are usually pretty comfortable. They're awake. Interacting with their family. Typically, for most of our cases, you're home in 4 or 5 days. So lastly, what are the risks and the benefits? So benefits, almost certainly you have symptoms. Aortic disease, a little bit different, but we'll talk just about valve disease. So typically you have symptoms. You're short of breath, you're lightheaded, you're dizzy, you're passing out. So the benefit is, one, symptoms. Two, with valve disease, your heart's working harder than it has to work. That valve isn't opening well, and so your heart's pumping harder, or that valve is leaking and blood's coming the wrong way, and your heart's having to pump 120, 130, 140% of the blood that it normally has to pump. So there's a lot of good benefits from it. What are the risks? Cardiac surgery today in general on otherwise healthy people is pretty safe. So I quote most of my patients around a 1% risk of death. Stroke, heart attack, kidney dysfunction, usually double to triple that. So if you're otherwise healthy, there's a 96, 97, 98% chance that you're going to have a really good result. So that's the general, what does it mean when someone says you need, should at least consider heart surgery? That's what, in general, it encompasses. Second, can the valve be repaired? So this is a picture, it's a surgical picture of a patient with an aortic valve. It's called a valve-sparing root. So her aorta was diseased, the valve was okay. So that's what a normal aortic valve looks like. So this valve was able to be repaired because where it was living wasn't healthy. So the aorta got big, it stretched it out. The amount of aortic valve tissue was not enough for the valve itself. So shrink that area back down so that the amount of valve tissue is enough for that area, you can repair it. This is what that patient's CAT scan looked like before. So we looked at the aortic root last time. The aorta is big. So if your valve isn't working because your aorta is big, there's a chance we can repair your valve. Now, most of the patients' valves that we operate on look more like this. So this is aortic stenosis. This is the most common mode that these degenerate, and 3 different pictures of them. This is not repairable. These leaflets are stiff. They don't open well. They're full of, those are calcium deposits. There's nothing we can do surgically to make these leaflets open and close again, to make it look like that first one. So when we see this, and we'll know preoperatively based on the echo, if you have significant stenosis, it's almost never repairable. Okay, so we can't repair it. What are the options to replace it? So there's 2 options. One is a biologic, tissue, all sorts of names, but it's a non-mechanical valve. So it's made out of living tissue. So this is a common one we use. It's an Edwards valve. It's made out of the lining of a cow's heart. So it's not actually the cow's valve. It's the cow's, it's called pericardium, and it's treated and it's hand sewn onto these struts to make an aortic valve. It looks almost identical to the function of a normal aortic valve. There are 3 leaflets. When it contracts, you can see that second or third picture in, it opens widely so that blood can be pumped out. And then when the heart stops contracting, it closes. So this is a very common, what we consider tissue valve that we use. The other option is a mechanical valve. So tell people these theoretically last forever. There's a 1% to 2% risk a year of having an issue, but they don't degenerate over time. Those tissue valves, as Dr. Garcia said, they can fail in a similar way to your native valve. Those leaflets don't open as well or don't close as well. And unlike your native valve, which probably got you 50, 60, 70 years before it started wearing out, those tissue valves, depending on a few factors which we'll talk about, are in the more 10, 12 to 15 years. So, okay, you find out that your aortic valve is diseased and you're 40, you're otherwise healthy, you're active, you have a long life left ahead of you. we may consider putting a mechanical valve in. That's not going to generate over time. You only need theoretically a one and done operation. So these are just a couple of different kinds that we use. There are multiple different really good mechanical valves. So this is a different mechanism, as you can see. It's discs. So the heart opens, the discs open. The heart beats, discs open. Heart stops beating, the discs close. The one caveat to this, and why we don't use them all the time, is you have to be on a blood thinner. And right now, in 2022, you have to be on Coumadin. Coumadin is it's the most common blood thinner that's been used for a long time. Its effect is somewhat affected by what your diet is. So you have to change your diet a little bit. If you want to stop it, it takes a little bit to reverse. If you want to start it again, it takes a little bit to reverse. So it's a little bit of a hassle. So most people don't want to deal with this if they don't have to. There are trials to drop your Coumadin dose. There are trials to use non-Coumadin blood thinners. So that may be something. 5 years from now, we may be saying something very different. But today, that's the answer. So which valve should I choose? There are 50 people in here. Everybody has different risk factors, goals for what they want. So for everybody, it might be different. But what information can I tell you to help you make the best decision for you? And the thing I'll say before I go into it anymore is most people, I tell them they can't make a wrong decision. If you pick a mechanical valve, and you have issues down the road, you made the best choice that you thought. If you pick a tissue valve and you end up having to have it replaced in 6 to 8 years, we don't know what each individual is going to do with that individual valve. We can just tell you in broad strokes what these things look like. So this is probably the best study on one type of valve, the cow valve that I showed you, and this is one institution's experience with that valve. So this is people that received the Edwards Paramount valve at 20 years out. So the top line, or the one on the top on the left, is people who are alive alive without needing a new valve. That second one is died with their original valve in, and that small green line on the right is needed a reoperative heart surgery to swap the valve out. And you can see that the number of people that needed their valve swapped out because it wore out is very low. 5, 6, 7%. Now, there are a lot of factors that, at 20 years. There are a lot of factors that go into it. Maybe they were too old, didn't want it, things like that. But in general, of all these people at the Cleveland Clinic that got Paramount valves, a very small percentage at 20 years ended up needing a redo. So what factors, that's everybody, so what factors affect how long your valve is going to last? So here's your risk of needing a new valve at 20 years. So if you're 40 and you need a new tissue valve, your chance of needing a new valve in the next 20 years is pretty high. That's 11, 12%. If you're 70, 80, 90, your chance of needing a new valve at 20 years is very low, 2, 3, 4%. So at 70, almost all we're putting in is tissue valves. In their 60s, if you're already on Coumadin for something, we'll put one in, but again, most people are choosing tissue valves. In the 40s and 50s, we're putting in more mechanicals. So one last topic, and this is not the aortic valve, but it's the mitral valve, and there's similar principles that we talked about. So as you can see, there's that one piece. It's the posterior leaflet of mitral valve, and it's flailing. It's moving up and down, and there's one small piece that's flailing. And that's what we consider excess motion. So if you have flailing things like that, that's another reason that we may be able to fix it. I'll show you some pictures to explain. So this is the mitral valve, the top and the bottom, 2 leaflets. That bottom is moving too well. So if it's moving too well, there are some things we can do. So One thing we can do is take out some of the tissue. So if you have too much tissue that's billowing, if we take out some of that tissue, less tissue will be there to billow, it won't leak. Another thing we could do is each mitral valve has normal, what are called cords that attach the valve to the heart itself. If those valves aren't working too well, if they're getting long, if that's what's causing some of the valve to move too much, we can oftentimes fix that. So, just in summary, there are multiple approaches to surgically treat valve disease: full sternotomies, partial sternotomies, incisions through the side of the chest. Open surgery is safe and effective for valve disease. Durable options exist for valve replacement. And when we see valves that we can repair, we do our best to repair them. Thank you. I'd be happy to answer any questions if you have any. Great. Thank you.
Okay, our next speaker, I met this man earlier today. He's got a lot of interesting stories, a lot of interesting experiences. He's a letter carrier from Duluth, Minnesota, and he's also an aortic aneurysm survivor. Please welcome Mike Sylvester.
Thank you, and thank you, Amy and Pete, for putting on this amazing event again. I'm just going to briefly summarize my health issues because I could probably spend 2 hours talking about them. I've told my story a couple of times here at Rock from the Heart. Some of my health issues include heart attack, ascending and descending aneurysms, ascending and descending dissections, heart valve disease, atrial fibrillation, stroke, and then the stroke gave me epilepsy. And yet here I am. After telling my story at Rock from the Heart 2 years ago, I was approached by the Alliance for Aging Research and asked to take part in their patient advocacy training. Because of COVID, we had to hold it virtually, and I completed that and was then looking for projects to work on in my spare time. So I worked with the Alliance for Aging Research, which is a large nonprofit dedicated to helping people live happier, healthier lives through the advancement of technology. So I did videos and podcasts with them. And then I also worked in conjunction with my healthcare provider in Duluth, Essentia Health. I did TV commercials, there were billboards, there were direct mailings. And I think a lot of my goals align with Rock from the Heart. There's diagnosis, there's treatment, and then there's recovery. And I've been through all three of those on a couple of different occasions, 6 heart and vascular surgeries in the last 6 years. And I think there's also another component, and you heard Karen talk about it earlier, and that's being proactive. So a lot of what I've been doing is centered on helping people become proactive. After having my first open heart surgery, they said, well, you're going to meet with your general practitioner every year. And who is that? And I said, don't know, don't have a doctor, don't go to the doctor. I said, well, that's going to change. And it did for me. And so I try to get the word out to people. Please go to the doctor, have them check your cholesterol, have them check your blood pressure, and have them listen to your heart. Those 3 things can make a huge difference. And so I've really been trying to focus on helping people manage those risk factors, because you can save yourself a whole lot of pain and suffering along the way if you just go to the doctor and have them do those 3 simple things. And I also am alive today because of a patient advocate. Following my open heart surgery, or my first surgery, which was for a heart attack and having a stent put in, I was in the post-anesthesia care unit, and I was sweating, and I was vomiting, and I was complaining of chest pain, and they thought it was just the anesthesia wearing off. And an echocardiogram technician took a look at the echocardiogram and said, this doesn't seem right, there's something going on here. And she physically went and got the cardiologist, and the cardiologist came in, took a look and saw that I had aortic valve regurgitation, looked at my symptoms, and I asked him later, and he said, well, you had all the classic signs of an aortic dissection, and he got me in for a 10, 11-hour surgery that I barely survived, and I've had 5 more since then. So because the one person took a few minutes to go get somebody to say, let's take another look at this, that's the reason I'm alive. So I've made it my goal to get the right information to the right people so that they're in the right place at the right time to make the right decisions, because I think for a lot of us here, that can really be the difference between life and death. Thank you, everyone.
Thank you, Mike. Well, we are ahead of schedule, so I've been given the go-ahead to talk about me for a few minutes. My name is Mike Preston. I'm an aortic survivor from the Chicago area. I have a background in stand-up comedy, but the pandemic kind of brought that to a screeching halt. So, you know, the pandemic reminds me of a quote from that great American philosopher, Mike Tyson. He said, everyone has a plan until they get punched in the face. And I think when COVID hit, a lot of us felt like we'd been punched in the face and all our plans flew out the window. And I know everybody had a lousy year in 2020, but I like to think my year was a little lousier than most, because in May of 2020, I suffered an aortic dissection. And as I sat there, gasping for breath, drenched in sweat, with my heart pounding like it was going to rip out of my chest, I remember thinking, I can't wait to share this with an audience. So here we are. Actually, what I was thinking was, boy, I hope this isn't a heart attack. Well, be careful what you wish for. There are worse things than a heart attack, apparently. So as I was sitting there, I started running down the classic symptoms of a heart attack in my head, you know, the tightness in the chest. And I'm like, no, there's no tightness in my chest. It feels like there's a machine gun going off in there, but it would not call it tight. And so that's good. And then the shooting pain in the left arm. My left arm felt great. You know, my left arm felt so good it was mocking the rest of my body. So I'm thinking, 2 for 2, that's great. And then I got the shortness of breath. And I think, I really got shortness of breath. I better call 911 because I have just exhausted my complete store of medical knowledge. So I called 911 and the paramedics showed up within minutes. Any first responders here? No, they're out saving lives, of course not. I'm a last responder. If you're having a medical emergency, don't call me because I'll try and help and then you're really screwed. So I called the paramedics and within minutes, they took me straight to the hospital and my future just got a whole lot brighter because they put me on Dilaudid. And I don't normally recommend drugs, but I don't normally get Dilaudid either. So, you know, in fact, I've found that if I ask for it, they won't give it to me. Dilaudid is just kind of like love. It only shows up when you're not looking. So they had me all whacked out, and the medical team came in and explained how serious my condition was and what they were going to have to do to me. And when they got done, because I was whacked out, I gave them my theories about what it was. And see, I thought it all stemmed from an abscessed tooth I used to have years ago, and I thought they should do certain things. And they were very polite about it. Nobody told me to shut up or anything. They just waited till I got done, and one of the doctors said, well, you know, that's a good theory, but, you know, we got these CAT scans and all these expensive machines, so we're probably just going to do it our way. Whatever. You know, you try and help people. So they operated on me for 12 hours, and because I wasn't awake to assist, it was successful. And then I was on a ventilator for 5 days, and they woke me up, and I could wiggle my toes. So, and I spent 2 weeks in that hospital, then another 2 weeks in physical rehab. And all the doctors and nurses' aides and therapists, everybody was great. Just an army of angels that put me all back together and saved my life. Everybody, although I have to say, between the masks and the accents, some of them were a little more difficult to understand than others. I was talking with one doctor one day, and I thought she was asking me about being a comedian, and she wanted to know if I did it in clinics or hospitals. I'm like, no, nightclubs and bars and things like that. So it turns out she was asking about my Coumadin. So now she thinks I get blood thinners in nightclubs and bars, and I don't. I've gotten a lot of drugs in nightclubs and bars, but never blood thinners. So she was great, and they put me on physical rehab. When I got out of that, they sent me into cardiac rehab, which is something I continue to this day with and I never thought I would be the kind of person who enjoys going to the gym, and I was right. I don't enjoy going to the gym, but when the therapist says stuff like, well, how badly do you want to live? Okay, I'll go to the gym, but I go to an old person's gym. I don't know if you guys have one of those. I call it Jurassic Park, but it's pretty obvious that a lot of us are there on medical referrals. Nobody looks like they're in training for a triathlon or an Ironman competition. Everybody looks like they're in training for a walk to the mailbox, including me. And you would think somebody in my condition wouldn't be so judgmental, but you'd be wrong. And my favorite thing to do is to stand on the treadmill and make up nicknames for everybody else in the place, like, there goes fatter than me guy, and uh-oh, it's Kenny Karaoke with his earbuds in, singing to beat the band, and there's one guy who looks like a disgruntled TV news anchor man, so I call him Dan Rather Not Be Here. And going to a gym during a pandemic is an experience in itself, because you walk in the locker room, and the first thing you see is a big sign that says, everyone must wear a mask at all times, regardless of vaccination status. And then you turn the corner, and you see a bunch of naked old men wearing nothing but masks. Then you got to ask yourself, how badly do I want to live? But no, I just want to say I really am glad. With the pandemic on the decline, I thought this would be a good time to get away, escape the Chicago winter, go someplace nice and warm, like Minneapolis in February, and I am glad to be here. When they first woke me up after being on the ventilator, everybody's telling me how lucky I am. You're so lucky. You're so, I'm like, really? I don't think that word means what you think it means, because I'm laying here in the bed with tubes and wires, and I can't go to the bathroom by myself. I don't feel all that lucky. I felt a lot luckier when I was sitting at home watching Netflix. I'm going to feel a lot luckier when we get this catheter out. But as the fog gradually lifted, and it became apparent to me how narrowly I missed, buying the farm, and it was miraculous that these people put me together and that I was able to wake up and wiggle my toes. I do feel lucky, and I feel very lucky to be here with you guys in Minneapolis in February today. We're going to take a short break, and then we'll come back and have some more speakers. So thank you for being here.
So one of the things that doesn't usually happen is we get this far ahead, which is a good problem to have when we have extra people that might have something to say. I don't know if my husband, Pete, would you just stand up for us? I won't make you talk, Pete, I promise. I cut my earlier intro a little bit short because I wanted to make sure that Karen, who traveled all the way from Maryland to be part of this, was able to have her time to talk. So I'm just going to go briefly and tell the story of how this all started. This is our vision. This is what I thought Rock from the Heart was going to be. Learned this new word this past year called imposter syndrome. And if you heard of that, I'm sitting here looking at this crowd, looking at how many people are watching this online, and the connections that were made 2 years ago, 3 years ago, online, 2 weeks ago in Fargo, and today. It's hard just to not get choked up when I see that, because I will always remember March 2015 when I was driving somewhere and Pete called me after his physical and he said, there's something wrong with my heart. They want me to come back. So I got home and he said they want to do something called an echo because there's this murmur thing that they've heard before. He remembered that the year before when he had his DOT physical, the doctor said the chiropractor doctor that does the DOT physicals local, he said, "You've got a heart murmur. Has anyone ever told you you've got a murmur?" Yeah, but they've always called it innocent. So it never made a second thought of that. But that day, our lives changed. He went in and got the echocardiogram, and then we got the procedural call where a nurse calls and says, "You've got aortic stenosis and a 5-centimeter aortic aneurysm that will require surgery." And Pete repeated that. I was in the other room in my office, so of course he's on the phone and I'm Googling. And my heart sank. I will never forget what that felt like when I looked it up. So hung up the phone. The nurse had told him somebody will call you within 2 weeks to do, talk to a cardiologist, see what's going on. And Pete looked at me, go, "I can't wait that long." So he called the clinic and we got in to see his primary care doctor, Dr. Prasanna, the one who took that extra step and said, "Let's take another look at it this time." So they got us in. It was within 2 hours of that call. We went into the clinic in Delano and sat down. And when Dr. Prasanna came in the room, before he even sat down, he looked at it, he goes, "Pete, this is a good thing. We found it and it's all fixable." And those words resonate with me probably nearly every day when I look at Pete and all the things that we've been able to do since the day he was diagnosed. Well, then you had the 2 years of watch and wait. Pete was borderline. His valve stenosis was mild to moderate, they said, or moderate to, kind of bordering on that. And the aneurysm was fairly stable at 5. We got a new cardiologist for the second 6 months appointment. The first one was good. He was very good, but the second one was phenomenal. He said, "We're going to take a closer look at this. We're going to get a CT scan. We're going to take you down to Abbott to look at that, where we got the really cool machines that can take a good look at this." And he really talked us off the ledge. Because what happens when you're in those watch and wait years is you're living in a roller coaster. This is your life, 6 months. You're like, appointment time's coming up, and the emotions start to come, and then you're here and they go, "Well," Pete goes, "I'm a bus driver, and we're off in the summer. Can we just wait till June? Because I'm off work anyway, so there's my 90 days that I can't drive in the state of Minnesota." So we did that a couple times, and then it finally came to June of 2017 when the valve was severe. The aneurysm still was pretty stable between 4.9 and 5, and Dr. Campbell said, "I think it's time. I think it's time." Pete goes, "Yep, I guess I better man up and get this done." So we did, and the cool thing that happened was I was on Googling all the time going, I just want to see somebody who's alive after this surgery. I want to see somebody living, breathing, doing the things they used to do after having this fixed. It's really hard to find that. It's really easy to find all the scary stuff. Well, it turns out one of our favorite drummers, Kelly Kagi from Night Ranger, had a heart surgery a few months before Pete's, and we didn't know what it was. They said he was going to be out for about 8 weeks. So in June, we noticed that Night Ranger was going to be playing at Rib Fest in Fargo. And we hopped in the car and we drove to Fargo because Kelly was going to be back behind the drums. And it was from the stage that night that they did announce that Kelly had had aortic valve replacement surgery 8 weeks before, and he was up there playing his drums, full 90-minute set. His drum tech did one song, I think, and he sang a few, but there he did. And I said, okay, there it is. And Pete calls that his Kelly Kagi barometer for heart surgery recovery for drummers, because Pete is a drummer. So Pete had his surgery about a month after. His surgery was July 12th, 2017. Another date that will always rest with me as kind of one of those never forget things. It was a week after my birthday and surgery day. Whew, what a stressful day that is. But what an amazing team. What a lot of people, I think, out in the world you see on the support groups don't have is that heart care team, where you really feel like it's not just that your primary care is not talking to your cardiologist, who's not talking to the surgeon, who's not. Every 6 months, Pete's cardiologist, Dr. Campbell, would call the surgeon and say, is it time? What do you think? Pete wants to wait. Can we wait? Okay, sure enough. Time, we'll go do that. So that we knew who the surgeon was forever, and we rode that together. And that was so impactful for us. So we wanted to help other people, and Pete laid in his hospital bed, and he says, when I make it to the other side of this thing, I really want to do something for other people so maybe they're not so scared, that maybe they don't feel so alone. And the idea really started with, well, we've done a few things at the Delano American Legion. Maybe we'll get one of your bands and we'll do a little thing and it'll be good to go. Like, okay. And we tossed it around and I said, well, why don't we just try to book Night Ranger? Do you think we can do that? The biggest thing I'd ever organized before Rock from the Heart was a concert at the Delano American Legion. So imagine the imposter syndrome that first year when we finally sitting in this room and I got the call that Night Ranger had arrived in Minneapolis and was in the lobby. So it was like, woohoo. The reason we added education that first year was really because of the amazing people at Aortic Hope who made the decision when we met through some mutual friends. Patty Peterson, I think, helped get us connected, and they decided to fly some of their team to Minnesota. I'm like, well, if they're going to come all this way, we might as well train. We might as well do some education along with it. And that's how this whole 2-day model was born. So I just wanted to share that with you, that it's because of community that we are together. When I look at the people in this room, Laura Lean, who's going to speak later, I saw a video that she had done for the American Heart Association with her story, and I'm like, I'd really love to meet her. She's been here with us every year. Just a few months ago was when Mike reached out. He found us through online somewhere and says, hey, I'm in Chicago. I'd really like to come and attend your event. And I said, well, we could use an MC, and we met for the first time in this room today. Dr. Ben Udelman, I'm through Karen at Aortic Hope. I watched a community collaboration thing, and I'm like, I want that guy to come to Minnesota. I think, what do you think he'll come to Minnesota in the winter, Karen? And here we are in this room with new and wonderful people. We've got Jennifer, who's going to speak later during the dinner about the health benefits of music. But what a powerful thing. We thought we were alone. When Pete was diagnosed in 2015, it was the most alone I'd ever felt. And here we are in this room looking at people, survivors like Kathy Jo Peterson, who found us in a support group, and drove to Waverly when we were volunteering at a bounce house of all things, just to hear Pete's mechanical heart ticking in his chest, to feel that and make that connection, because she had just been diagnosed and was pre-surgery. I mean, it's just amazing, and we really are glad that in the middle of winter, post-pandemic, and all the craziness that's out in the world there, that you made the decision to choose to come here to be in this room today with us and share in this. Again, we hope to grow this every year. We hope that you'll share this with your friends, follow us on social media, give us ideas on how we can make this better and reach more people. On that note, with even a few minutes, Kathy Jo Peterson actually has somebody here. Did she want to talk for a few minutes? Are everyone's okay to keep our break at 3 and just keep the party going? You can sure introduce her, Kathy Jo. Go ahead. So thank you all for being here again. It's just a wonderful seeing the faces in the room.
I'm talking later, but I'm going to ask if you had surgery, planned surgery, were you afraid? And for those who have not had surgery, were you afraid? And they tell you that they want to wait as long as possible because it's dangerous, and they're going to, not do it when you're 45, they're going to do it when you're 60. This is Rosie. She had open heart surgery at age 80, unplanned, a year ago.
79.
No, you're 81.
Well, I was 79, no.
She's arguing with me about
I'm
how
80.
old she is.
Come on,
She's
I'm
80.
I was born in 1941. And I was a very active 79-year-old. And suddenly I was very tired, more tired, and didn't want to do things. And I was starting to have trouble breathing. And my son, who lives in Fairmont, Minnesota, he's coming tonight, said, Mom, you don't sound right. What's going on? And I said, I don't know. I'm just very tired and just don't feel good. And he said, let me talk to my sister. And she's a PTA. And so he called her in Colorado and said, something's wrong with Mom. She's just not herself. And so she called me and she said, Mom, I think that maybe you have pneumonia. She said, you can't breathe. She said, go to the emergency room and tell them you want some oxygen and that you have to come home because you're caretaker for Dad. My husband had a stroke 5 years ago. And so I came in at about 3 o'clock in the afternoon. I got a good friend to give us a ride to the hospital. And they did some testing, and they said, you don't have pneumonia, but what you have is something with your aorta. And we're going to do surgery now. I was at the University of Minnesota, no, at Fairview Hospital. But it turns out that the University of Minnesota is the heart hospital. And so I had to take an ambulance over the bridge to get to the hospital. But, and I could feel, but then they did the anesthetic and I knew nothing till when I woke up the next morning, or whenever I woke up. And was where I was awake and alive, because they said there was a possibility that I might not survive this. But I did, obviously. And everything was going fine until they used the heparin, and I was allergic to it. So they had to refine blood thinners and heart medications and the whole bit. So I was in the hospital longer than I thought I would be. But then I went to rehab and then came home and went to cardio rehab. We had home health care at the house first for a while, and that helped a lot as I got stronger. And my son said, I'm going to buy you some new clothes, Mom, because you can't put on the T-shirts you usually wear, because you can't get your hand above your head. And, you know, I couldn't lift anything for a while, and bit by bit. But I did obviously recover and am back to normal, except that in August of this year, my husband had a heart attack. So now I'm caregiver to a heart attack person. But it decided last week that it was time to give us both a little relief, and we're going to leave our house and go into assisted living in a very beautiful place near our house. So a lot of changes, but I'm here to tell the story. And so if you have somebody that is having trouble breathing, get it checked out, because that was my only clue. That I couldn't breathe and I was really tired. And now I know why. Thank you.
Hey, I'm Pete, one of the founders of Rock from the Heart. Thanks for coming. Yeah, I just wanted to say hi, and we're going to take a short break. I always let people hear my heart valve if you want to hear a heart valve. If you've never, come find me. I put deodorant on, so it's pretty safe to get down there. Anyway, thanks for coming. This is pretty awesome. And I'm looking forward to hearing this gentleman up in front speak after the break. He came in from New York, and I'm like, okay, this will be cool. I've never met anyone from New York, so I'm excited. Thanks, everyone.
risk factors or symptoms with ease. Yeah, we're here to tell you that hope's on the way, that heart valve awareness is today. Listen to your heart, keep your health in your sight. Listen to your heart, if something doesn't feel right, go see your doctor and bring a loved one along. And listen to your heart, speak up so you can stay strong. It impacts babies and the oldest ones here. 25,000 lose their lives every year. Yeah, but there's good treatment for those seen in time. Access is key, 'cause life turns on a dime. Listen to your heart, keep your health in your sight. Listen to your heart, if something doesn't feel right, go see your doctor and bring a loved one along. And listen to your heart, speak up so you can stay strong. We need your voices to help spread the word. It's so important that you make sure you're heard. Living with valve disease is real today. Let's make it happen. We all know the way. Listen to your heart, keep your health in your sight. Listen to your heart, if something doesn't feel right, go see your doctor and bring a loved one along. And listen to your heart, speak up so you can stay strong. Listen to your heart. Go see your doctor and bring a loved one along. And listen to your heart, speak up so you can stay strong.
Okay, Dr. Benjamin Udelman is a cardiac surgeon who specializes in endovascular and aortic surgery and performs all types of cardiac surgery. He is the co-director of the Maimonides Aortic Center in Brooklyn, New York. He established Aortic Bridge, a support group in New York City for patients with aortic disease. Dr. Udelman completed his fellowship at the Hospital of the University of Pennsylvania in endovascular and aortic surgery. Please welcome Dr. Benjamin Udelman.
Hi. I'm going to just turn the podium as opposed to everybody else. All right, can you guys hear me? Fantastic. Green button, I hear, for the last couple hours. No. There we go. So, New York City, it's quite an interesting place. You guys know there's a lot of parks, beautiful open spaces. You know, some people actually just want their own personal space, so what they do is they carve out just little spots where their kids can play, which is just a really lovely thing. I don't know if you guys are familiar with this. Was big in the 1920s. They were called baby cages. This is not a joke. This is real, and it really was there. Of course, pizza is number one. Anybody from Chicago, who I don't know if anybody who shall remain nameless thinks Chicago has the best pizza. But this is on the left, you have Giovanni. On the right, you got Salvatore, of course. And I went in there my first Valentine's Day in Brooklyn, and I walked in. I'd been in there maybe twice. And I said, Giovanni, I got trouble. It's Friday. It's Valentine's Day. What are we going to do? And he goes, I got just a thing. And they made me that Valentine's Day pizza. And I took a bunch of pictures, and then I made them a big, huge thing on the wall, which was really kind of cute, and they loved it. So Brooklyn is a huge city. It's the fourth largest city in the United States if you actually would do it by the numbers, but of course it's inside of a much larger city, 8.8 million people. And in the bigger city, there's, I think, 60 hospitals. Brooklyn, there's only 10, but we are the only heart hospital, and we're the only hospital that does aortic surgery in Brooklyn. There used to be 2 heart surgery programs, and they have since folded. So we do kind of all the work there. Some of the people in the fringes, they go to other places, but it's a pretty crazy place. Aortic center is a term that gets thrown around a lot. And the concept of an aortic center is just a full service location where you can go and get your aorta evaluated. We've heard talks from cardiologists, we've heard talks from surgeons, and the whole issue of the aorta, and what I believe everybody really wants, is a full-service boutique approach to their bodies as a whole. The problem is it's really hard to do in this healthcare age, and we're trying to figure out the best way to do that. But if we fix your body and your mind is left to sort of squander with the internet, God forbid, you are going to have a really lousy existence for the 20 to 40 years that you're waiting either to get surgery, or 20 to 40 years, hopefully, that you'll live after surgery, waiting for your next, horrible thing to happen. And so we have to do a much better job. So we're going to talk a little bit about what we're doing in New York, of all the crazy places to be doing a better job for something like this. And then we're going to talk a little bit about education and outreach associated with aortic hope. Karen Anderson, one of the most phenomenal human beings I've met in a long time, with the exception of my wife, please record that. And then we're going to talk about outreach and education associated with both Aortic Hope and Think Aorta, which is now the largest international campaign to raise awareness on aortic disease. So if you look at the left side, you have a normal aorta, and on the right side, you have a very abnormal aorta. You have an aneurysm of the ascending aorta, an aneurysm of the arch. If there was a pointer on this, not associated with the green button, I would show you, but I think most people can see what looks funny. And these are often found incidentally. Incidentally meaning I went in because my toe hurts, and oh, by the way, I had chest pain 3 weeks ago, and you get a CAT scan, now you have an aorta, now you are freaking out for months on end, and you don't know what to do, and you're now seeing somebody like me who you never wanted to meet in the first place. And I don't blame you. I I respect that. So you repair the aorta like this. Anybody who's going to pass out or throw up, just put your hands over your eyes. Most of us do this sort of thing because these are interesting pictures. On the left side of the screen is an aortic aneurysm. Yes, it does look like that with all the blood vessels going through it. It does heal itself. Tears are not torn and then it's just destroyed. It's not like it's just sitting there, it's a live breathing structure. But we replace it with nylon. Nylon doesn't expand, but you can imagine that the junctions where the nylon touches the heart or the nylon touches the nylon are very dangerous little spots, and that's where a lot of these problems can occur postoperatively, which is why we follow you for life, which is why you're stressed out for life, okay? Just so everybody understands what the problem is. Aortic dissection, whole nother ballgame, okay? The critical thing here, and everybody watching in the far-off reaches of Minnesota, these are different things, okay? An aortic dissection is a tear. Everybody's heard me who's ever met me. A is in the ascending, B is in the B-sending, right? B is in the B-sending, and the reason B is in the B-sending is because you're never going to forget that. And the reason that they are separate is not because they're not dangerous, it's because of what we do as surgeons. Historically, A's were operated on immediately, B's were never operated on before they became a problem. That is not the case anymore. We're going to talk about that a little bit. So if you have a dissection, you get a CAT scan, you can see it looks different. You got this line down the middle, and everybody goes, oh my gosh. And the one dissection that this emergency department physician has seen in the last 3 or 4 years, and they go, oh my gosh. And now they've just upset your entire family, upset you, upset everybody under the sun, and it's a complete disaster. Why? Because they're upset, because they never see them either. And then they call me, and I come down very calm because I see them pretty much every week. In fact, I didn't tell you this, Karen. I got off the plane, turned my phone on, and it just blew up with 2 pictures of a CAT scan and aortic dissection that I had to then, help mobilize people. The patient's doing great, by the way. So I'll give you the name so you can send one of those gift packages. Thanks so much. So when you have an aortic dissection immediately, you can have anything under the sun. This is an aortic root. This is a mechanical root replacement. You heard a little bit about that stuff. And this gets descended on sort of similar to that string art that we all did in 4th or 5th grade. We kind of put it all together. It's exactly the same as the string art, except it's a little more exciting than the little owls that we made on that board. You remember with a stick sticking out? Yeah, same concept though, generally speaking. But things get very complicated with aortic dissections. And sometimes instead of just having one nylon tube, you can have multiple nylon tubes. You don't have to take a picture. I can get you these slides later if you need it, okay? Just pay attention, right? They say some things are meant to be photographed, others not, So the idea that the branches that go to the brain and the arms need blood flow, and if there's an abnormality, you have to actually make sure that they get adequate blood flow, and that's a big problem. But your abdominal aorta can have an aneurysm. If there's a dissection in the belly, it's called a type B because it's in the B sending. Yes, you got it. You guys are getting good at this. Branches in the aorta in the abdomen are very much different. They go to your intestines, they go to your kidneys, eventually they go to your legs. But we have some phenomenal new stuff on the horizon. We have fenestrated grafts and branch grafts where we can put in these grafts in the event of aneurysms and dissections in the belly and get into these little tiny branches, right? So everybody's all excited about the aortic valve. That's been out for 10 years commercially available. This thing has only been out for 2 years. Nobody even knows about some of this stuff. The idea being that as we go all the way down the aorta, we can really reconstruct a lot of it doing minimally invasive endovascular work. So am I out of a job? No way, because we have not really moved the needle on a lot of this stuff in 20 years, despite all these efforts. So we'll talk about that some. So somebody said pseudoaneurysm and they had a rupture. So this is a really interesting case I wanted to tell you about. So on the left, you see the blue, is it blue? I'm colorblind. Is it blue, purple, whatever, that arrow that's not yellow, shows a little blip on the aorta. That's a rupture. And the reason it's particularly interesting, does this come off? I'm going to do the rock star thing here for a second. So the reason this is particularly interesting is that this very nice lady had this stent graft placed here about 9 months earlier. I'd been following her for a couple of years when she ruptured here. So she comes back in, oh, my chest hurts. Well, that's disappointing. So then she ruptured over there, and that's associated with this dot right there. So that's not a small problem. That is a rupture spontaneous in the ascending aorta. The ascending aorta rupture is not a dissection. It is worse. Sounds crazy, right? How could it possibly be worse? Well, the reason that it's worse is that when an aorta ruptures, there's got to be some other issue going on. And when that other issue is going on, you know that the aorta is going to be really, really, really diseased. And so I, in my moderately marginal artistic merit, came up with this plan because we had to take advantage of this particular lady who was constructed a little differently than the average bear. The blood flow to her right arm actually came off as the last branch all the way on the left side of her body, traversed around behind her trachea and her esophagus, and then went off to the right side. We took advantage of that, reconstructed everything, and then put in a stent graft in the ascending aorta. Not common. The way we did this is, as you can see, is we took advantage of the one in the bottom left-hand corner, that circle, same circle up in the upper left-hand corner, reattached all the vessels across, and then put a stent in the ascending aorta. So where you see that arrow where the blip is right in the middle of that stent graft in the ascending. Now this type of stuff is not done everywhere, and it's not done commonly, and sometimes, quite frankly, it's not successful. But these are the advances that we're making to try and keep everybody safe. Because if we can do this in a 76-year-old lady who, if she underwent open surgery, might have benefited from living in a nursing home for the rest of her life with a tracheostomy on a ventilator, maybe, and we're able to do this, and she was able to survive, then we can certainly handle all of you otherwise healthy people, right? Easy stuff. So let's go to talk about something a little less grotesque. The community that you guys have outlined in the last few number of talks is phenomenal. I mean, I sit here in awe, right? I do this as a surgeon, but you can imagine I go home and, I have to deal with other things at home, like, 2 80-pound dogs and completely crazy children and stuff like that. And you guys have to go home every minute of every day and think about this. And I know that. I really do know that. And Karen knows that I know that. Aortic Bridge was my first formal salvo into creating this organization that was going to support patients, and quickly followed up with Karen. And quite frankly, COVID has helped a number of things in our work, even though you would be like, well, that's crazy. But no, it actually has. And I'm going to go through a bunch of things. Our ability to capitalize on the fact that COVID just kicked everybody in various parts of their body, depending on, what you have. Thank you for getting that joke. I appreciate that. You appreciate it. One person in the crowd. It gets you to the next joke, right? It just needs one. We had patients who were suffering from nothing, who were just fearful at home that they were going to die of a disease they'd never heard of, from a place that they've never heard of, that was affecting body parts that they barely even knew. And on top of that, we had all of you who had real diseases that they were concerned about. What we did during all this period of time is we really worked very hard to integrate everything formally. We always had psychiatry see all of our patients who were getting a heart transplant, who were getting an assist device, because really, you walk up to a patient and you say, hi, your body can no longer survive without this mechanical thing. Would you like to talk to somebody? Versus you guys have the, hi, your body's about to blow up. Would you like to talk to somebody? I mean, it's kind of a crazy concept, but no one ever had psychiatrists see patients who had the type A dissection, let alone all the other diagnoses. And we've formalized that. Every patient with aortic disease sees a psychiatrist. The psychiatrist shows up to our support group meetings. She doesn't do a great job of coming to our combined support group meetings at night, but she used to come because there was food when it was in the hospital, But anyway, she's very nice and she's very helpful, and she runs the consult liaison psychiatry service at the hospital. So all of you who are going to go back to your hospital and ask, you say, we would like to integrate the consult liaison service of psychiatry into the aortic program. And that's fundamentally what you need. So what we did with the help of Karen Anderson is we created a survey that combined the PTSD evaluation with a couple of questions about COVID, because everything was COVID for the last 2 years. And we sent it out into the world, and maybe some of you or many of you have answered this survey. And this survey was fundamentally designed to answer a very simple question. Not did you guys have post-traumatic stress disorder, but how bad is it really? Because we know seeing patients who can no longer function and perform the activities of daily living after having a type A dissection with a totally intact functional body is not because they physically can't do it. It's because your brain is getting in the way. And our study, which is going to be presented, this is the first presentation at an aortic meeting. It's been presented at a psychiatry meeting where all the psychiatrists are all excited to talk about things that they talk about all the time. This was accepted for publication at the American Association for Thoracic Surgery Aortic Symposium in Boston in May. And if you think that that's a small issue, I will tell you that is massive. To have other surgeons care, to use a nice, general, non-threatening word, care about this topic is awesome. And to see them care about this topic is really fantastic. And the reason that they care is not a small part of all the work that you guys have done here and that Karen's done and the tiny little microscopic amount that I've done when I wasn't doing my other thing. What did we find? Well, on the backdrop of known 5 to 10% post-traumatic stress disorder in the United States, with a known event of at least 5 to 20% of anybody who had standard heart surgery, we found that people with type A dissection were almost 50% occurrence, 50%. 1 out of 2 people had a dramatic psychological effect of this condition that made them unable to function in their daily life for a small or large period of time. That is unbelievable, okay? That is an unbelievable number. And if you asked anybody like me who does this for a living, they would say, oh, I believe that. And what have they done about it? Nothing. So our purpose for doing this is to show everybody that this is a real problem and to integrate psychiatry into this. But if you look at the other stuff, and I don't remember who said it, oh yeah, you have this condition, but don't worry about it, go home and don't think about it. So the watch and wait group, right? 12%. 12%. So you may say, well, that's not very high. The day before you got told to watch and wait, it was 0. And then in one day, it's 12%. That's massive. It's a massive difference in your life. That every single 6 or 12 months, you have to go up and down and up and down. And 12% is probably the average. It's not the up, right? And it's not the down. So what are we all doing here? We are trying to do that preactive strike to the world and say, if you become educated about aortic disease from soup to nuts, then you can probably do a hell of a lot better job of taking care of these patients than we've been taking care of. And I promised you that I speak from the literature in cardiac surgery, the literature in medicine, and the literature in psychiatry, that we've been doing a crappy job of taking care of all of you in order to have you get back to healthy and productive lives. Do we fix your aorta? I think I do a pretty decent job of that. Do we fix your valves? They have really good valves. That's great. But that doesn't help you. It doesn't help you when, I don't know, the percentage of people that cannot go back to their jobs, the percentage of people that feel like they are totally incapacitated, that they need to go on lifelong disability, that they are totally messed up with this fact because nobody came to them right off the bat and said, here's 20 people who just had this diagnosis. You're going to be fine. Okay, let's talk to them. Okay, now you're going to go into surgery. You're going to come in. You're going to be fine. Okay, now you're going to talk to them again. And then we're going to send you a nice little care package. And you're going to come to these support group meetings every month. And then you're going to come to a big cool thing. We're going to talk about it in a room. And then we're going to go to a rock concert. It's going to be really awesome. Now, that's the way to do it, right? If that's the way it was done for all of you, I promise you that your stress level would be way down about this diagnosis than what happened to all of you. We did not do this by ourselves, and we did not sit there. I wrote letters, and a bunch of other people wrote letters to all of the governing bodies, the American College of Emergency Physicians, the Society of Thoracic Surgeons, and the Society of Vascular Surgeons, and a couple of the 2 Eastern groups, because we're in the East. And they all signed on to Think Aorta in order to spread the word, because they know, hey, this is big. This is a big and important thing. Distribution of material, raise awareness, and increase the knowledge about how common aortic disease is and its inheritance patterns. And you're going to see Think Aorta, Think Family a million times on the internet, and you're going to see it a million times from me and Karen and a bunch of other people. But let's talk about what that really is. Inherited diseases are many, many, many. And I don't want you to think that there's just these 5. But let's just talk about the ones you know. Everybody goes to the doctor. Heart attack, stroke, diabetes? Yes or no? Heart attack, stroke, diabetes? Yes or no? If you say somebody died of cancer, they'll go, ooh, cancer. And I stand up here before you, the lucky recipient of BRCA2, which you may say, oh, that's the breast cancer gene. Well, I don't have breasts, but I do have a pancreas, a prostate, and what else do I have? I have something else. Oh, and a GI tract, all of which get affected by that because it's not a breast cancer gene. It's a cancer gene, okay, everybody? Cancer genes. There's vascular genes and there's cancer genes. And we can all split hairs about which part and where you're going to go and your problem. Does anybody want a cancer gene? Anybody want a vascular gene? No, you don't want any of these things. But they all come down as gifts from your parents. You don't just get those nice, the copper colander from grandma and the nice dish set and the silverware that you never use because every time you use it you have to hand wash it and it's a total pain in the ass. You also get genes, and this is the big deal. And if you look at these numbers, and it's easier to do it in terms of deaths, and I'll tell you why. Because these are the real numbers that are on death certificates, right? And then what about aortic disease? Well, at least 10% of the population has aneurysms. And how do I know this? I'm going to tell you in a second. But here's what I wanted you to know. There are 20 genes and counting, 20 genes and counting. Some of the genes are shifting to the left, and some of the genes shifted to the right. To the left are the really, really, really unfortunate souls. Those are the people who are walking around with normal-sized aorta and have a dissection. And they come in, and you operate on them, and you ask them, where's your mom? She died of a dissection. Where's your dad? He died of a dissection. Where's your grandparents? They died of dissections. Okay, did anybody tell you this is inherited? No. Really, 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 really bad. Somebody asked me, what do you define as an old surgeon? An old surgeon is a surgeon that doesn't know about this. A young surgeon, young, handsome, and somewhat tall, although balding, with a personality that defies my hairline. That's what a young surgeon is. Somebody who knows that when you teach somebody, patients and residents and medical students alike, you must explain to them that everything is inherited, and we have no idea to what degree. In 1999, the human genome was sequenced. 1999, that's 22 and a half years ago. We know nothing about the human genome. We know a lot about those little fruit flies, you know, the Drosophila melanogaster, you know, because we had that sequence like 50 years ago. We don't know anything about the human genome. We think we do. So all the genetics that you see are just scratching the surface. So if you have it in your family history, you have a great chance of getting it. That's all we're going to say about this over and over and over and over and over again until everybody learns it and does something about it. We took advantage of COVID. Another positive about COVID, I mean, there weren't that many, but here's one. Definite disadvantage was me having to breathe my own breath all day long, especially for a long operation without having to brush my teeth 15 times a day. I was the last man standing after two of my colleagues got COVID. One guy went out for another health problem. Another guy worked at a different hospital. And for 2.5 months, I was the only heart surgeon at my hospital. But there was no surgery because everybody was at home dying from various conditions, not just COVID, because they were afraid to come to the hospital. But the ones that did, they got a CAT scan because that's all we had. So they were getting a CAT scan as a diagnosis for COVID. So I was sitting there day after day, bleary-eyed with coffee, bored out of my skull, reviewing 1,500 CAT scans. And what I found was unbelievable to everybody who I work with. And it's unbelievable to all of you. And it's been unbelievable to everybody I've told about this, which is that I found an incidence of aortas that were greater than 4 centimeters in a population that spans 90 plus different countries in Brooklyn. I don't know if any of you have been to Brooklyn, but there's a lot of different people there. This is not Minnesota, you know what I'm saying? Not that you guys have only one people here, but Brooklyn is a little different. Almost 15% of the population has an aortic aneurysm greater than 4 centimeters. And if you go to 4.5 centimeters, which you saw a lot of people put up there, it's because 4.5 is a real aneurysm. 5% of the population. 5% of the population of Brooklyn, which is almost 3 million people. You think we're seeing that many people? No chance. They're not coming in. But they come in when they have a problem, and then it's picked up incidentally, and that's the problem. That's the fundamental problem. The other side of the story is that 30% of patients with aortic dissection on the left side of that screen, they also get dissections, and they don't even have an aneurysm. So all the people that we pick up, we still got a bunch of people that get it, and they don't even have anything that you're going to be able to physically see or listen to know that they're going to have a problem. So what do you know? What happened to your mom? Oh, she died of a massive heart attack. How about your dad? Yeah, same. Excuse me? On and on and on and on. We have to change this paradigm. That's what we're doing here at these types of events. We're changing people's brains to understand what's really going on. All we have is to ask about family history, and all we have is to image these patients. And if you're adopted, somebody in this room is adopted. If you're adopted and you don't have any of that history and you don't have an aneurysm, I can't tell you that you're not going to have a dissection. So I don't want anybody who's not had an aortic problem to now leave in this watch and wait fear that something bad's going to happen to them. But pay attention to the family history far more than you did before. And tell everybody, not for fear that something terrible is going to happen to you, but so that you can go to your doctor, now that you have a doctor, thank you, and you can get evaluated and you can get identified early and things can be done. You have to think aorta, think family, you have to think cancer, heart disease, stroke, diabetes. It's all the same. We are now in 8 countries, and I say we because I've been involved for, 2 years now, I think? 8 countries, but there's more coming. There are countries where this will not work. This may not work in the United States, but we're going to do our very best, and we're all going to do this together. So what about paramedics? I already saw there was no show of hands that anybody's a paramedic. So paramedics are awesome people. They get, varying training depending on how much they want to do. And they go into people's houses to pick up somebody who's not feeling well, and they ask these 6 questions. Signs, symptoms, allergies, medications, past pertinent medical history, as opposed to the past useless medical history, which we all, your last oral intake, your last menstrual period, and so what happened? Events that happened. But they don't ask anything about family history. So let me go through that. These people, they walk into the house where the whole family is standing over you. They ask all these questions. They don't ask anything about the family history. Then they leave and take you to a hospital 20 miles away. You don't get there because the family, they've got to go to, the men have to go to work, right? The women then have to go to work and stay home. Then one daughter, usually, thank God I have 2, goes to the bedside, and they say, any family history? Daughter, I have no idea. But they didn't ask when they were standing there with the entire family. So we went to all of the paramedic training people and asked them to put this in their training. And they said, oh, yeah, well, it's not really pertinent for us. It's not that important. They just redid the entire EMS training curriculum. And when I sent emails to every single member of the board and asked them to include it, they said, well, we already have something like that. It's not necessary. It's not that important. It's very, very hard to get people to understand. But here's some crazy, crazy, crazy facts. In 2004, the U.S. Surgeon General, 2004 is almost 20 years ago, thought that this was so important that they created this whole website, which nobody in this room except me has ever seen. I don't even think I told Karen about it, but there's no way she looked it up. Because there's no reason to look it up. But you can input all of your family medical history and all the nuances and stuff in order to have everybody know in government what's gone on with your family's medical history. You sensing a problem here? Everybody sensing a problem? Yeah, this was doomed for failure from Jump Street. But they did it. But they did it because they knew it was important, but nobody followed up on it. And when I met with a very nice gentleman named Fleetwood Lustelat, I know it's a mouthful, but that's what his name is, and his 5 colleagues who head up the CDC Heart and Vascular Division, and I met up with him, I think it was the 23rd of January 2020. You guys following me? January 23rd, 2020. Had a very nice meeting with him. He was ecstatic about this. He was so excited about this. He thought it was awesome. He has been distracted for 2 years and has no interest in receiving any emails from me anymore. But at the time, prior to the other shoe dropping about COVID, 1 week after I met with him, he was pretty interested. And why was he interested? He was interested because of facts like this, which is if you sift through the literature, and I have a bunch of them, but this one is ridiculous because I promise you that I didn't know this after going through just a little bit of medical training, and I promise that nobody in this room knows that either. It is unbelievable that if you have an appendicitis, that other people in your family probably had an appendicitis. Now, if you think about it, it makes sense. The appendix is this thing that's sticking off of your intestines, and if yours is prone to block, then maybe your parents is prone to block, and maybe your grandparents was prone. It all makes sense if you think about it, but there's no way that they taught me this in medical school and that anybody knows this. So how could you possibly help with this situation? Appendicitis is one of the most difficult diagnoses. Yes, CAT scan is helpful, but it's a really tough diagnosis. And if the paramedics went into the room in the house and asked the whole family, does anybody else have appendicitis? Everybody raises their hand. Well, then they can go in and tell the doctor. What do you think the emergency room doctor would say if a paramedic said, the whole family's had appendicitis? He'd be like, that's nice. I'll take it from here. Because people don't even know about this stuff. We have to change the paradigm of aortic disease and learning about aortic disease in this entire country and in this entire world in order to save the lives of all the people that you guys have heard of and to make you guys have elective surgery as opposed to the emergency surgeries that you've had. calcium scoring CTs are being offered from most unions and most large groups. So if you work in a big company with greater than 500,000 people, they're offering it so that the insurance company can know and get you diagnosed and treated and put on the right medicine so that the insurance companies don't have to deal with you getting an operation because it's really expensive. Let that sink in. Lung cancer screening is done for everybody who smoked so much that they probably have cancer. Okay, that's brilliant. But there's no CT scan for someone who's got a family history of aortic disease. What do you think is the actionable data associated with those top two? You think it's more than the third? I don't know, because there's no data. But I will tell you that if you took someone at 50 years old and you did a scan and looked for lung cancer and looked for calcium and you looked for an aortic aneurysm, you're probably going to find something. And they'll probably be able to help them change their medicine, maybe even save their life. How is that going to happen? Probably 50 years from now, maybe longer. But all of these things dovetail into early diagnosis and treatment, which we're all working towards. We all joked when we were in medical school in the 90s that when we turn 50, which I already have, we're going to get a head-to-toe CT scan. We're going to find all this disease. They're going to pluck all these tumors out of us. And then all the data started that people are having a bunch of incidental unnecessary surgeries and dealing with all the complications and that the numbers don't add up. And I was like, oh, that's disappointing. I thought that was going to work. Then I find out I have this other problem, and then I was like, oh, that's not going to work. Every year, I get 2 MRIs. Every year, I get an endoscopy. Every year, yes, I get a mammogram. Hugging that machine is weird, I got to tell you. It's a very awkward. Only the women know what I'm talking about. Trust me, it's pretty weird. It's pretty funny. I have pictures. No, I'm not going to show them to you. But if you have a patient and there's no history of aortic disease and they all live to their 90s, does that mean they don't have an aortic aneurysm potential problem and that their hypertension shouldn't be controlled? No. It just means their families didn't rupture. Great. Good for them. But if you have an 8-centimeter aneurysm, I'm going to operate on it. That's it. End of story. And if you're, adopted, like we talked about, it's a bummer. I want you guys to read this. Should I read it for the people in the far corners of Minnesota, or can they see it? They can see it? Oh, good. Okay. So read it at home, please. Thank you. It's so obvious to me that if you look back at your family history, if you have it available to you, and if you look forward to speak to your siblings and your children and their children about all the diseases in your family, and don't freak out about it. Just talk about it basically, about it's facts. These are facts. Then they can protect themselves. I don't care what it is. Our objective is not just to save everybody from aortic disease and let them all die of heart disease, stroke, diabetes, and cancer. No, our objective is to have everybody think about this in a better way. The reason that this campaign works is because it gets everybody paying attention to what actually matters. And why does it matter? This is why it matters. You guys may have heard about these walks that we do, which are now, we're all in this together, right? Karen and me and all of you, we're all in this together. You guys want to fly to New York and come and walk across the Brooklyn Bridge? It's one of the most absolutely spectacular bridges in the world. Obviously, the view is pretty good. Yes, I pay for food afterwards, so that's also good. This year, we had a total of about 110 people. 90 of us walked across the bridge. 20 of us just met us at the bar. I can't do anything about it. Listen, what am I going to do? But every year we have this walk, and what we hear from everybody, and these are not just patients and families. These are my team too, my team. We all work together because we're all trying to deliver a different type of healthcare. And I'm not the only one. There are a lot of really great people out there trying to do the same stuff. And all of you know physicians that do this stuff. We all just have to do this together. Thank you very much for having me here and for doing this and for allowing us all to do this together, because there's no question that doing this all together, we're going to be way more successful than doing it by ourselves. Thanks a lot.
Our next speaker is a video presentation. So Patricia Keegan. Patricia Keegan is a nurse practitioner from Atlanta who is the program director for the Structural Heart and Valve Center at Emory Healthcare Heart and Vascular. She received her master's in nursing from University of Alabama at Birmingham and her doctorate in nursing practice from University of South Alabama. Her career started at Emory University Hospital as a bedside nurse in cardiology. She participated in the care of the first TAVR performed at Emory in 2007. She now serves as the program director for the Structural Heart Program. She has co-authored multiple publications and has been invited to speak nationally on structural heart disease. Please welcome Patricia Keegan.
Okay, thank you. So I'm honored to be able to participate in this program. My name is Tricia Keegan, and I am the director of the Structural Heart and Valve Center in Atlanta, Georgia. And again, thank you to Amy Johnson and the team from Rock the Heart for inviting me to participate. Organizations that provide access to information and patient empowerment are needed partners in the healthcare journey. I thank you all for taking the time to participate and share your knowledge and stories. So when you think of Atlanta, which is where I'm from, perhaps you think of some of our teams. Maybe these are some that you might be familiar with, our World Series champion Braves or our Georgia Bulldogs. However, I would like to introduce you to our Rockstar team. I think it's amazing that this team has a shared true north, which is helping patients regardless of job title, function, or background. So what is a team? So I know this definition is very textbooky, but what it says is true. The team needs to work collaboratively with the patient. We describe this model of care as patient-centered care. As well, much of what we do on the structural heart team is to work with the patient on shared decision-making. Much of this occurs in collaboration with the patient and the team. The patient is the chief decision maker of their care, and our job as the team is to provide the information for the patient to make the best decisions for them. What we want the decision and what we want the team to do is to provide safe, effective, patient-centered, timely, efficient, and equitable care. By definition, the team is more than one person making a decision. The team, in essence, works for you, the patient. You have an entire team that is invested in your health and well-being and here to guide you through the process of making decisions regarding your health care. Having clinicians of different backgrounds, education, and experience can provide expertise on various aspects of your care. What do you need to know pre-procedure? What do you need to know during the procedure? And how can your recovery be successful? We all want what's best for you. I made sure to include some important milestones that are with my team. Number one, we have a female cardiac surgeon who also trained in interventional cardiology, and we had our first all-female TAVR team. So our interventionalist, our cardiac surgeon, our anesthesiologist, and our fellow were all females. We have an amazing cath lab staff who helps guide you through the process, as well as our team of nurses and ultrasound techs and imaging techs who help make your process much easier. So why do we have a team? The team model is really good for everyone. We see higher quality and positive patient outcomes. Obviously, these are important to all of us and our patients. Right now, having a work-life balance and decreased burnout is essential for our healthcare providers. Working in teams evens out workloads and decreases burnout. So what we see from this diagram is that we want increased efficiency because we all want to be able to move through the system safely and efficiently. We want quality care, and of course, we want positive outcomes. We know that getting patients through the system and being able to treat them safely and efficiently helps to have better outcomes. So why do we have team-based care? So in 1999, there was a report that came out from the Institutes of Medicine called To Err is Human. What many of us remember about this report was the number of medical errors that were responsible for patient harm each year. And what they showed was that this number was astonishing, somewhere between 44,000 and 98,000 patients per year. In 2001, the Institutes of Medicine released a second report called Crossing the Quality Chasm. In this report, the Institute of Medicine recommended 6 aims for improvement. And these were kind of guides that told us what should we be focusing on to improve our patient care. The aims were safety, effectiveness, equity, timeliness, patient-centeredness, and efficiency. Working with teams helps to achieve these aims. But in the early 80s, 2 important studies showed the benefits of surgery versus medical treatments in stable coronary artery disease. Both these studies used the heart team, and this included a cardiac surgeon and a clinical cardiologist. And what they did is they selected patients for eligibility and randomization. So this was really, as they say, dogs and cats working together, or just opposites attract, so to speak. And so what we did is we saw with these patients that the teams worked together, and they showed that the heart team minimizes poor outcomes. It helps to grow our culture. And so it also minimized errors and facilitates evidence-based decisions. In 2016, a survey among involved physicians, the most important characteristics of a heart team were as follows: collaborative, multidisciplinary, beneficial, necessary, and positive. And I think that's some really good insight about being part of a heart team. We saw a lot of these teams originally in transplant and oncology. We had nurse navigators, we had social work, we had separate specialties that were working together, even pharmacy who participated in the care. So again, we had a lot of guidelines to show why this is the way that we should have been moving. When it comes to teams in TAVR, what's really interesting is the original trials when it came to structural heart interventions had the surgeon and the interventional cardiologist evaluate, treat, and provide care for these patients. And then in subsequent trials, we actually saw that these patients, again, we kept these components of the trials. We had research who participated in this process, imaging from patients who underwent echocardiograms or CAT scans, anesthesiologists, our cath lab nurses, our staff nurses, advanced practice providers became involved. This was also where we really saw the advent of the valve clinic coordinator. And this was really the start of the multidisciplinary team for valve patients as we know today. So when we look at our multidisciplinary heart team, we saw that through industry, they were really the big creators of, really kind of guiding and looking at our expertise from the heart team. And so what first came out was that the members of the heart team, again, include the referring cardiologists, the coordinators, surgeons, interventionalists, our cath lab staff, and all of these patients, all these came together. But really, one thing that we also really came to include was the patient. The patient is an integral member of our heart team. It's the center to which all the other pieces come around. So for this particular diagram, I really like this depiction of the heart team from Brennan et al. It has the patient in the center, and it includes our medical colleagues. But then what's really important is it also includes the patient family. And when we talk about the patient's family, we don't necessarily mean blood representatives or blood relatives. What we talk about is family is whoever the patient says family is. And this is really important in patients' recovery. It also includes other specialties. Maybe if you have kidney problems or lung problems, we include this team. We also include rehabilitation. So when we talk about cardiac rehab, they are definitely a part of your heart team as well. So let's think for a minute about who impacts your care. As you can tell from this slide, there's lots of areas of people that affect your care. This list certainly is not exhaustive, and you may come into contact with or have a part in your care. Some of you may never see, like the insurance team or the scheduling team. But what we do see is when you think about when you walk into your doctor's office, who do you see? Do you meet the medical assistant, the front desk clerk, the check-in, check-out person? They're part of your team. When you come in for procedures, our admissions colleague, the nurses, the physicians, our advanced practice providers, dietary, environmental services, they're all part of your team. When you go home, your team at your local cardiologist, at your cardiac rehab center, your family, they're all part of your team as well. So when we talk about guideline-based care, there is a number of organizations that help guide medical practice. And this isn't just for cardiology, it's for a lot of disciplines. In the world of cardiology and in cardiac surgery, we do have a number of organizations. These are the American College of Cardiology, the American Heart Association, the Society of Thoracic Surgery. And so what happens is sometimes they come out with these recommendations. And so we do know that a lot of disciplines are involved with patients undergoing heart valve surgery. Over the past few years, these organizations that focused on heart disease have worked to put together these guidelines to guide the care of our patient. Guidelines give general recommendations of how to perform a task or advise on how to proceed in a situation. The American College of Cardiology and the American Heart Association are just two of the organizations that help serve as patient advocates and guide our cardiology practices. In the past number of years, they have put out a number of recommendations or guidelines when it comes for the treatment of cardiac disease or valvular heart disease. And so at the end of 2020, they came out with these guidelines for treatment in patients with valvular heart disease. So when we talk about the guidelines, we obviously want to cover what we saw in these guidelines. So the top circle here looks at evidence, strength, and then the recommendation. So the COR is a class of recommendation. This is the strength of the evidence. LOE is the level of evidence. This is the quality of the data. And for this, we look at research trials and expert opinion. In our guidelines, the organizations state that having a multidisciplinary team is necessary, and you should see patients being considered for valve procedures. As we read papers, we look to see if the paper is scientifically sound. This statement was made with a strong level of evidence and expert opinion. So what does this mean for our patients? If you go to your provider and you have a heart murmur, and that heart murmur comes back and it says you have aortic stenosis or mitral valve disease, if there's any consideration that you might need treatment, sending patients to a multidisciplinary heart valve team is clearly recommended by our guidelines. When we talk about the second item here, we talk about indications for transcatheter aortic valve implantation are expanding, and this is as a result of multiple randomized trials of transcatheter aortic valve implantation versus surgical implantation. The choice of type of intervention for a patient with severe aortic stenosis should be shared decision-making process that considers the lifetime risks, the benefits associated with the type of valve, and this means just mechanical versus bioprosthetic valve, and the type of approach, transcatheter versus surgical. We still are continuing to work on gathering data on this section, but again, going to a heart valve center is reasonable when it comes to these treatment options being discussed. So how certain are we that the heart team should be involved in your care? Well, what we did as an organization or as a government is we tied payment for these procedures. So there's something called the National Coverage Determination. And this is what it is, again, going back to what we talk about guidelines, is Medicare guidelines for participating hospitals to get paid for doing the procedures. The committee saw the evidence and believes that the heart team is essential to care, that they included having a heart team in their rules for payment. Per the ruling, the heart team is not just a one-time meeting. The heart team is involved in care throughout your process and the patient's treatment. This includes pre-procedure, during the hospitalization, and even post-procedure. The collaboration became so essential that in 2012, the Centers for Medicare and Medicaid Service, which is called CMS, mandated a heart team approach for all patients receiving TAVR as a prerequisite for reimbursement. This was continued when the guidelines were updated in 2019. For patients with coronary disease, the European Society of Cardiology guidelines recommended this concept as a class 1 indication, which means that it's highly recommended, and as the use in 2010, and then the US guidelines followed suit in 2012. So when we know what must make a good heart team, so there's components of a heart team. And so the teamwork must provide an atmosphere of trust, positivity, cooperation, and effective communication as necessary components of making the team successful. Trust is the underlying foundation of any good team, not just the heart team. Without it, no team can succeed. Furthermore, having a positive attitude is key to help solve problems rather than harbor them. Cooperation and effective communication is necessary overall for leaders to role model and teach, which encourages our staff to climb on board when tackling new initiatives or projects with a team attitude and an optimistic perspective. Time and time again, teams outperform individuals because they generate enthusiasm and high energy. So when staff works together to achieve and deliver results, patients have improved outcomes. When we talk about care models, it can be a little complex, and we like to put together big fancy graphs and things like this, which is what you see here. But what we know is that patients who have any kind of issue, we can't just do it alone. It has to be about more than just a procedure. We see that in this chronic care model, not only does it include the health system and the decisions that we can help with, or our information systems, tracking medical records or what our process is, but even working within the community to how we can help you be a success with dealing with any medical issues. We have informed, activated patients, which means that you have the tools that you need to be successful and make decisions. You also have to have a good practice team who wants to have productive interactions. And this goes both ways. It's not just a physician or a advanced practice provider or a nurse telling you what to do. It's what do you feel is right, and how do we work together to get those great results? When we all work together, we have improved outcomes. So here we're just going to talk about kind of putting models into practice. We've talked a lot about the role of the team, and we've talked about what makes a good team, and that, the guidelines suggest that there's a team, and even we need to have a team to get paid for doing these procedures. And so, but what does it look like when we put it into practice? And so this paper by Wang and team looked at the relation of post-discharge care fragmentation and outcomes in TAVR implantation. And this was from our national registry, where the data goes into about patients and outcomes. And what this paper actually looked at is patients who were discharged from the hospital after having TAVR. So what did they see when they wrote this paper? Well, number one, the authors looked at patients who had transcatheter aortic valve replacement between 2012 and 2015 at 374 sites across the United States. Then it looked at what they called fragmented care. And fragmented care was defined as if a patient had to go back to a hospital after they were discharged from their TAVR, that they went to a hospital that was different than the one who did their TAVR. Most patients, unsurprisingly, received what they called fragmented care, and that was 57%. And these patients had higher rates of readmissions and illness at 1 year. So this was, having your TAVR at one center and then seeking care at someplace else. That was, honestly, this was most of our population. And it was noted to have increased mortality and all-cause readmissions. The longer driving times were associated with higher rates of fragmented care. So if it took you a long time to get to the hospital where you had your TAVR, that you'd want to go someplace close, right? So lastly, there was an unequal geographic distribution of TAVI volume. So that meant that there were centers that were not equal, that they were harder to get to, longer to get to. Some states may only have one TAVR program where other ones have 40. So how do we make this care accessible to all? So how do we fix this? So your heart team needs to coordinate with your local team and your support team. We want patients to be taken care of locally when possible. And how does this happen? Our teams need to be aligned. After all, we have the same true north, which is your care. We have physicians that are designed to help you recover and know where you can seek help. Sometimes this can just be knowing who your family should call, or getting your medical records where they need to be, or making sure your social support knows how to best provide care when you recover. This includes cardiac rehab as well. So this problem, it showed it was a problem, but our team, we have to work to fix it. So what's the first step? I did what everybody does, and that's I Googled, how do we have a successful heart team? Unfortunately, no easy answers came up. So the second thing, I said, well, okay, what makes a good team when I changed my search? I'm not only looking for a good heart team, but a good team in general. In a real team, all members have shared goals. There's interdependency, so we rely on each other. And it's not easily achievable when multiple specialties are involved. And for that reason, the heart team can only perform its purpose if it becomes a real team whose decisions are not based on hierarchy, unbalanced information sharing, or hidden agendas. Best practices recommend a standardized heart team meeting, a protocol with defined timeframes, leadership, role of team members, discussion culture, and process of decision making. If these evidence-based recommendations can be adopted, optimal decision making and optimal patient care can be achieved. So what makes a great team? You have to have knowledge. You have to know what you're talking about. You know how to treat patients, and you have that insight. Cooperation, sometimes it requires some negotiation. Flexibility, how can we meet our patients where they're at? Common goals, we all have that same true north, and that's excellent patient care. Dedication, I think you'll find that people who work in structural heart disease and cardiology and heart valve are some of the most dedicated individuals. You've seen them with speaking here today, and you're going to continue to meet them upon your journey. And as I've been reading the Whova app and seeing a lot of the commentary, I can see that that's true. Planning, sometimes it takes some time and effort to know where you have to go, what time you have to be there, and all about the medication. And then effort by all. So how do we come across as, everybody pitching in to make sure that patients have excellent outcomes? So when you go to a center and you're looking at what that team looks like, make sure that they have elements of your team. Together, everyone achieves more. So I'm not sure that Taylor Swift is as lucky as Grand Funk Railroad to play for you all tonight. However, as Taylor Swift would say, there is no I in team, but there is a me. We all need to play our individual part in making this team work. Collaboration, knowledge, and participation are all needed, as well as making sure the patient voice is heard. You are the center of the team. So with that, I want to thank you. Thank you to Rock from the Heart for inviting me to take part in today's presentations. Thank you to the survivors, patients, and caregivers for sharing your stories. We will all become better by listening to each other and learning from our stories. I appreciate the opportunity to continue to learn from you all. Thank you for sharing your heartfelt messages. It's been very much appreciated, and we all look forward to growing together. Thank you for your time.
Thank you, Tricia Keegan. Our next speaker, Laura Ross. Laura Ross is a cardiology physician assistant at the Park Nicollet Heart and Vascular Center near Minneapolis. She graduated from Rosalind Franklin University of Medicine and Science in Chicago. She has been elected to the ACC Interventional Leadership Council, executive board member for the Association of Physicians Assistants in Cardiology, and the Minnesota ACC Chapter Council. Please welcome Laura Ross.
Everybody, I'm thrilled to be here, and to be in an in-person conference is just fantastic. And heart disease is a cause very close to my heart. We have a relative who at 102 had been hospitalized many times with heart failure and was told he was too old for anything, living in a small town in northern Minnesota. And thank goodness he ran across someone who was like, there's this new procedure called a TAVR, let's see how you do. And he lived until he was 107 with only one more heart failure admission after that. So all these talks I dedicate to Millard. He was just such an inspiring person. He did have to downgrade from the banjo. I know many of you are music lovers. It was a little too heavy as he got over 100, so he switched to the mandolin and would play for the old folks in the old folks' home. So I thought you might appreciate that story. Well, yes, I am also very passionate about food as medicine. So we know food is fuel, and you have heard so many great speakers today talking about imaging tests, talking about surgeries, talking about importance of cardiac risk factor management, and that's so important in the short term. But what I really hope to inspire you today is to think about, so many of you have made decisions about your aortic health. What else can we do to protect you head to toe from strokes and heart attacks? And I think food as medicine is an important part. So yes, I work at the Park Nicollet Heart and Vascular Center in Methodist Hospital, and it says disclosures none, but I do want you to know I have a few disclosures. I'm a lifelong vegetarian, married to a hunter, otherwise a perfect match. I have a twin brother who is a cowboy and recruited me to work on a cattle ranch in Wyoming for 3 summers, a vegetarian, if you can imagine. So I really learned that an all or nothing approach is not necessary to see real benefits. And in fact, in my own family, we have a family history of early heart disease. So my twin brother, although he looks like a cowboy, horrible cholesterol, borderline blood pressure. And my husband, who runs marathons, his dad had a heart attack, his first heart attack at the age of 35. So I had a vested interest in figuring out how to lower his risk. And in those personal experiences, cutting out Mountain Dew, cutting back on processed meat like bacon and things like that, both of those men in my life did not need medication. So I was excited to share that with my patients. I've been at Park Nicollet for almost 20 years. And over the years, started to collect some recipes, made a grocery shopping list, and surprisingly found significant drops in blood pressure, sugar, and cholesterol. So we're going to talk about that a little bit more today. And let's see, is this to advance the slide, I bet? Maybe? Green. Oh, that's okay. Thanks for bearing with me, guys. Am I missing it here? Thank you. So, chronic disease is a big issue. Over 133 million Americans have chronic disease. Now, 80% of that is because of lifestyle factors. That's 3 in 5 adults. And it comes at a huge cost, $3.5 trillion, and 90% of our spending is on chronic disease. 80% of it being preventable. So we all know smoking is a big risk factor, and in fact, worldwide, annually, 8 million deaths can be attributed to tobacco use. But poor diet is 10.9 million deaths globally per year. It's overtaken tobacco as the leading cause, and as you'll see in the slides, the top causes isn't McDonald's, Burger King, and Culver's. There are other causes, actually, things we're not eating enough of, the good stuff, so we'll talk about that. And red meat, I think most of us know that's associated with cholesterol, but there's a big increased risk of also diabetes. So there's a study that showed people who eat 2 servings or more of red meat have a 40% greater risk of dying from a cardiovascular event. So just cutting back on how much meat you eat a day. And half a serving of red meat a day, an extra half serving, led to an increased diabetes risk by 48%. Kind of staggering. So I really wanted to dive into this more for my heart patients and for my family history as well. And here are the 4 leading causes. It is not enough fruits and vegetables, not enough nuts and seeds. In fact, the Mediterranean diet recommends at least 30 nuts a day, about a fourth of a cup. We're not picky. Whatever kind of nuts you want, you're gonna get vitamins, minerals, fibers. It's like God's perfect gift of the balance between fiber, fat, and protein to make you feel full and have these minerals that are hard to get other ways. And then not enough whole grains. The low fat, and low carb, you may have heard about this keto diet that's been around. Short term, there can be good effects. People lose weight pretty quickly, their sugar can go down, but there's no long living population that survives on the keto diet. It's horrible for cholesterol. And in fact, if you don't eat enough whole grains, that's another risk factor for not only heart disease, but GI cancers. So I think of fiber as something that soaks up cholesterol, it soaks up toxins, and then it scrubs out your arteries and your colon on the way out, preventing those cancers and heart disease as well. And so if some of you have read The Blue Zones by Dan Buettner, he talks about these pockets around the world where people live long until their 100s without chronic disease. And there are a couple things these communities had in common. Plant-based eating or plant-forward diet, including some fish, is one of the main things that tie these communities together. Now, interestingly, the one population in America that fit the Blue Zones was not Minnesota. I don't know why, but it was actually in Palo Alto, California, where they had a pocket of Seventh-day Adventists who don't eat meat for their religious purposes, and they reached the blue zone without chronic disease. So I think it's fascinating. And so if we talk about modifiable risk factors, we're just not talking about lowering the cholesterol, lowering your sugar, it's actually preventing deaths. Now, most of us grew up with that food pyramid. I still can't really remember what's on the bottom, what's in the middle. But we thankfully got an update to the Harvard plate, and this is how you describe it to patients. Half of it should be fruits and vegetables, and more vegetables than fruit. About a fourth of it should be that whole grain. Now, they've made it easy. You don't need Instapots to make whole grain anymore. You get those little microwave packets that you tear the corner, put in the microwave for about 90 seconds, and you have a couple cups of barley, brown rice, quinoa, 7-grain blend. This is what helps soak up our cholesterol, evens out our blood sugar, and helps get rid of the toxins. And so adding more whole grains. And then a fourth of the plate should be a lean protein. Now, beans have been around forever. That's a great, cheap source of protein and fiber. Lean meats, I didn't invent this phrase, but I love it. They say, think of meat like a condiment or a condiment, something to have a little bit of flavor on the side if you want to sprinkle it on top, but it no longer should be the center of our plate, like it was when I worked on a cattle ranch. So that's one way. And fish at least 3 times a week is what's part of the Mediterranean diet. And so trying to incorporate what are some other plant-based proteins. There's a lot of meat substitutes now, Impossible Burgers at Burger King, and chick patties, made out of wheat gluten. And it's easier than it used to be. I think those are great as a busy working mom. I love the plant-based chicken nuggets and things like that. They're a great transition. And if we think of food as kind of a totem pole, I really don't think of food as being bad or good. It's just what's healthier and maybe not as healthy. And so when you are looking at what your choices are, what's the healthier choice for that day? Definitely a plant-based chicken nugget versus something else that might have more cholesterol and more processed stuff. So then when I meet with patients in my cardiology clinic, I really want to find out their why. Are they really passionate about the environment? I had a patient who was in his 80s, and every time he came, he'd want to talk for hours about global warming. And it was very stimulating, but I was like, I have another patient. I finally kind of talked to him about, you can make a difference by eating more plants and less animal products, and we finally found that middle ground. And when you think of a goal, the SMART goal is an acronym. So the S, make it specific. Think of one thing you can do starting today to increase your intake of more plants and less animal products. Make it specific. Write it down. Make yourself accountable. Tell someone in your home. Get an app that helps keep track of things. Find a pet you can be accountable to, something like that. And then make it measurable. Something, when I meet with my patients, we pick a couple goals they're going to work on. I say, I'm going to have you come back or call me in 2 months. Where's your cholesterol at? We'll check it. Where's your blood pressure at? We're going to talk about it over the phone. So there's something measurable, and it's time-bound as well. And make it relevant to that why. You want to lower your glucose. You want to be on diabetes medications. How can we get to that same goal? And then make it achievable. we can't say our goal is going to be to run a marathon on Friday, right? That's today. Definitely not. So kind of trying to work together on that. So based on all that information, I started something called the Heartbeat Clinic. And I went to my leadership and say, hey, I have about 40 patients I've tried this on. All of them had had heart attacks before or had risk factors. Look at these great results. But I need to be a little more than a one-woman show. And they said, sure, you figure it out, and we don't have any money, so good luck. And so I'm creative. I'm a little persistent. And so I worked with our employee well-being team. So they had health coaches, they had dietitians, they had staff that knew much more about statistics than I did. And so we decided to make this official and do an 8-week pilot study. And I love this quote by Michael Greger. He wrote the book with a catchy title, How Not to Die. Sounds good. And he said, we should all be eating fruits and vegetables as if our life depends on it, because they do. So keep in mind, it isn't, don't ever eat a cheeseburger if that's your favorite thing. It's just eat more plants. That really is what I hope you take away from this talk. And so this is the pilot study. We just enrolled employees because our coder knew they had our employee insurance and could double check every lab I ordered, every visit that we had, and really make sure we were being reimbursed. And then we also, oh yes, my leadership said you have room for maybe between 30 and 40 participants. And within 36 hours, we started a waiting list. There were so many people interested. And look at that timeline, September to November of 2020. So you may not remember that far back, but we had a pandemic, we had no vaccine, there was a little bit of a contentious election, and we were working with employees at a hospital during a pandemic. And yet, you'll see, our results were really positive. So I like to say that. And again, the no funding. At the end, we found out the dietitian visits, every participant met with a dietitian, and depending on your insurance, the cost came back at over $500. It broke my heart, especially because we had no funding. So I quick did some grant writing, and we did get a couple of those patients reimbursed. But I really learned our health system has a lot of work to do, as many of you know, to pay for the forward care and prevention versus we'll pay for it after your heart attack. And here's an outline that we sent to our patients. I'll review in a little more detail. We really decided to make each week about one of the pillars of lifestyle medicine. We'll talk about that more in a minute. They all met with a cardiology PA. I recruited a few of my friends who were passionate about food as medicine as well. We had bonus sessions, so I'm a little bit scrappy. I went right into Hy-Vee. I heard they had a dietitian and said, hey, will you do a grocery store tour that we'll film during the pandemic and show people? Where do you find nutritional yeast or coconut aminos or jackfruit pulled pork, those sorts of things. I went online and found vegan chefs who did cooking demonstrations. And so we really tried to be creative in how we did things. Okay. Teased me, there we go. So the first pillar of lifestyle medicine is a plant-predominant diet. So really, most of the visit with a PA and a dietitian was talking about what their concerns are, what are they doing now, what are some achievable goals they can do for the future. And then we had a dietitian talk about nutrient density of food, how to avoid the blood sugar roller coaster, how do you feel full without eating meat. My mom still thinks it's a fad that I might die not from protein deficiency. So there's a little education to do within my own family. And then we had our cardiologist, Dr. Pawan Hari, talked about kind of his experience with food as medicine. The next pillar was regular physical activity, so finding joy in movement. Just on Wednesday, we're doing another heartbeat round right now. We had one of the yoga instructors teach a salsa dance, and we had all 40 participants doing salsa in their living room, and I haven't done that for a while. We had so much fun. So it doesn't have to be, running on a treadmill. What can you do to find joy? And our cardiac rehab head talked about finding joy in exercise. Restorative sleep. So sleep is so important in feeling good for the next day, from healing from surgery, for handling stress. 80% of pain control is getting a good night's sleep. And so what temperature should your room be? How long before you go to bed should you avoid blue light? About an hour, by the way, to really get into that deep restorative sleep. And then stress management. We had a psychologist from Regents Hospital, who's a sister partner with us, talk about stress management during a pandemic, avoidance of risky substances. We have a substance misuse program at Regents, so one of their therapists talked about that. We have a mocktail demonstration next week. We'll send out the ingredients and we'll make mocktails together. And then positive social connections. They met with a life coach who really talked about that importance during a pandemic. How do you still make those connections? And then here's kind of the roadmap. So everyone got surveys before they started the program. We're in our second round now, talking about what's your food intake like, what's your mood, how's your sleep quality, how's your interpersonal relationships, and then after the program completed, they filled out the same survey. Then everyone met with a dietitian and PA, like I mentioned, and then we printed out a 2-week menu plan. None of the recipes were more than 5 sentences, and on Instacart, it was less than $200 for a 2-week menu plan. And we said, take what you like. About 90% of what we cook is 9 recipes. And so even just incorporating 3 or 4 new recipes in your repertoire that are plant-based can make a big difference. And then podcasts and books and documentaries. I mean, I thought maybe a little more information than not enough. I mean, the information's out there, but to get it from a trusted source in your cardiology department, I think was a little more unique than Dr. Oz or whatnot. And then we did the weekly meetings with the Pillars of Lifestyle Medicine I mentioned, and then they did small groups of 3 to 5 people met with a health coach to kind of talk about what are their goals. They reviewed the book Atomic Habits. How do you go from coming home from work, laying on the couch and watching Netflix, to coming home at work, putting on your tennis shoes and doing something? So this can't be all covered in one visit. So I was so appreciative for the employee wellness program to help me with that. And then the bonus sessions that we mentioned. And so after that spiel, what we found is about 80% of our participants said most days or every day they did plant-predominant diets, and about 20% was a few days a week. So there was no mandate on what they had to do. It was really patient-defined, which is a little unique in the literature, but I think much more sustainable for our meat and potatoes Midwest. And by the way, I was born at Methodist Hospital where I work now, so I have a vested interest in this community. And so what you'll see is there was almost a 50% decrease in those who ate an average of 4 to 6 servings of animal products a week, from almost 11 servings a week down to 3.25. And there was a 41% increase in those who ate an average of 4 to 6 servings of plants, up from 6.8 servings to 10.3. So those humps really changed in the right direction, which we were hoping so after that education. So after all that, what did we find? 100% of our participants saw an improvement in something, some objective measure, whether it was numbers of their cholesterol, their BMI, or body mass index, what's an appropriate weight for your height, or their sugar. And then, I can't quite read that, 63% I think of participants moved from an unhealthy range. So in healthcare, we have parameters for what's their LDL goal, what's the HDL goal for good and bad cholesterol, what's their systolic or top number of the blood pressure goal, what's the bottom number of blood pressure goal, what's their ideal body mass index. And 63% move from an unhealthy range into a healthy range. There's no medication that can help us do that with very limited side effects, right? So 70% of patients improve their blood pressure, 71% improve their LDL, or that lousy cholesterol carrier that brings cholesterol and packs it into the arteries. And what was fascinating to me, because I had never talked to anyone much about sleep other than sleep apnea, was that 70% of our participants rated their sleep poorly prior to the program, a complete shift to 70% rating it positive after the program. And there's some thought that meat or animal products can promote some inflammation. For some people, they notice some sensitivity to dairy and whatnot. And so how is this all connected that we could see improvements in all these things? And so we had our paper published just a few months ago looking at the significant differences we found in the study. So over 70% improved their LDL or bad cholesterol, an average of about 8 points. That was statistically significant. And over 60% improved their cholesterol with a difference of almost 7 points. Over 70% improved their blood pressure. Now, what was fascinating is that the systolic blood pressure measures how high is the pressure in your arm when your heart pumps the blood out. Dropped 5 millimeters of mercury. That doesn't sound like much, but at a recent cardiology conference, there was a big study that came out that was hailed as a huge success called looking at renal denervation, where they take out the nerve that goes to your kidneys to help control blood pressure. And it was hailed a success because it dropped the blood pressure 5 millimeters of mercury. So you can do that or eat more plants. I think one sounds more, little less side effects. And then we did see some drop in the diastolic blood pressure and weight, but it wasn't statistically significant. And so how about some of those other fluffy measurements, you know, that I care about but don't get a chance to really look at with patients as much? So how they perceive their general health significantly improved pre-program and after program. Up to 17% people said they described their general health as pretty good. I'm just going to step out here a little. And then fatigue. More people describe that as feeling, less people describe fatigue, and then describing their physical health, only 3% said it was excellent before the program. That jumped up to 25% of participants said it was excellent after the program. And then social and mental health measurements, you can see the right movement and more people describing that as excellent moving from pre to post intervention. So satisfaction with relationships and mood. And then here's the sleep quality graph where you can just see it went from poor to terrible to good to excellent after the program. And then we had a chance to ask them about other things like, how's your energy? Over 60% said their energy improved. How about your mood? Over half said their mood improved before and after the program. How about your clothes fitting differently? 47% said their clothes fit better. And then 17% said their physical pain or discomfort improved. And for most patients, that was arthritis type pain. Now it was interesting, they were doing another lifestyle medicine project at one of our other hospitals, and we had more pain improvement with a big focus on food as medicine compared to the program aimed at chronic back pain. So I thought that was really interesting. And then the 22% who said other improved was really GI symptoms, heartburn, irritable bowel syndrome, constipation, things like that. And here are some of my favorite quotes from participants. So we saw, all my cholesterol numbers improved. I learned new recipes, less joint pain. A couple people lost more than 10 pounds, although on average it was just a pound or two. And I love the second to the last one is my LDL improved significantly because this is a patient who had a heart attack, who's already on 2 cholesterol medications, and we were thinking about adding an IV expensive injectable medication. And for the first time after this program, her LDL was to goal. She no longer qualified for the medication. And then the last patient is a great employee who has a disability that makes it hard to cook for himself. And so in reviewing the resources, my sweet family tried all these meal delivery service programs, and I had shared with him Hungry Root, which sends pre-cut vegetables and proteins and sauces to your house. Everything takes less than 10 minutes, and he was able for the first time to kind of cook for himself and dropped his cholesterol and weight and felt much better. So we've shared this on the Whova app. This is a list of resources that I've worked on with American College of Cardiology, as well as in my own practice, really looking at what are some digital resources from the National Lipid Association, from the American College of Cardiology. The Association of Black Cardiologists has this beautiful PDF that has great recipes from the South. And then looking at other resources, I wrote Rooted Green Wellness is a fantastic resource we have in Minnesota. It started by a man who had his heart attack at Regents Hospital. And after that, totally changed his life around, lost 50 pounds, reversed his diabetes, got off a lot of medications, and he and his wife started a wellness clinic where we have done a couple projects together to help walk employees and patients along this healthy journey. And they have free webinars and free classes, some with low cost, but generally a great deal for your money, and can walk you through that journey, and they're hilarious, which always helps. And then I also wanted to point out the last one, the big switch. So if you're looking for a change, this is a free website where you type in, I like spicy food, or I can't handle Thai food. What's your cooking level, expert or novice? And it will come up and populate with cooking videos and tell you what recipes to buy. So you can cook along with them and kind of learn some new skills and recipes, which is great. And then one thing that's not on here, if you're looking for a quick and dirty version or overview of why would I want to eat more plants, there's a Netflix documentary called Forks Over Knives. They have a website as well, which talks to the scientists who did the China study, who started to really understand this correlation between food as medicine, and a journalist who makes some of these changes and how he feels and how his labs improve. So it's really fascinating. Talks about the environmental impact. So to get the quick version in a little over an hour, it's a fun date night. My favorite snack, by the way, is popcorn, because that counts as a vegetable. And then you put butter-flavored olive oil on top and sprinkle it with nutritional yeast, which is kind of like Parmesan cheese. It's kind of salty, has all the B vitamins, but without the sodium part of it. So that's a good snack to watch that movie. And then let me see here. Oh yes, at the end is the meal delivery services. So some are meals that are frozen. Sweet Earth is another brand they sell at Super Target that has 5 servings of vegetables and whole grains in every one. So that's a great way if you need something quick. But Hungry Root, again, is the one that a lot of my patients try. They've got edible cookie dough with chickpea flour and black bean brownie batter and cauliflower chips along with their meals that you can order. And they have teriyaki salmon or organic chicken if you're interested in including that as well. So I know that's a lot of information, but I really appreciate the opportunity, and I hope I've inspired you to pick 1 to 10 goals. Maybe we'll just stick with 3. Goals of things you could do. Try a plant milk. Try eating 30 nuts a day. Try incorporating more vegetables on your sandwich, or eat a side salad. And those are ways we can see can make really big changes. And so I thank you for your time, and I'll stay for question Q&A. I don't know if we should do that now or later. How are we doing on time? Yes. Oh, thanks. I'm so glad you asked. You read my mind. So I thought the same thing, and I asked our Health Partners Insurance, which our employees have, and they said, we don't cover the hsCRP, which is an inflammatory marker thought to be sensitive to the heart arteries, which is ironic because it's considered a risk-enhancing factor in the guidelines. But I did get a grant, and we checked it on everyone in this round, so I will have the answer for you later as far as the hsCRP. But that's the main inflammatory marker we checked this time. Are there others that you're thinking of we should include? Yeah. Okay, we'll be in touch. I think it'll be fascinating. There's a lot of studies that a vegan diet can lower these inflammatory markers, and I'm hopeful, I'm optimistic we're going to see that it will come down just with eating more plants and a little less animal products. Any other questions? That was a great one. All right, well, thank you for your time. Oh, we have another one, yes.
I was told a number of years ago that your taste buds can change as you get older. And I'm a notoriously picky eater, and so I'm not a huge fan of vegetables. So are vegetables one of those things that as you get older, there's still some hope that maybe they will start to taste good? Or is it kind of like, you know what, that ship has sailed?
Oh
like,
gosh,
I'm not gonna
what a great question. I'm so excited to have the opportunity to answer this, because the short answer is yes. But the longer answer, is that it takes 3 to 4 weeks for our taste buds to change in regards to how much sodium we eat. That's pretty well studied. As far as other foods, we can assume it's the same thing. And the nice thing about vegetables is you can put them in the air fryer for a different texture. You can roast them, you can cook them, you can blend them up and put them in zucchini bread. You can eat it in different ways. They now make so many vegetable chips that have whole grains and then lots of other things in there too. But I would give it a good 3 to 4 weeks in cooking it in different ways. And there's so many vegetables. It doesn't have to be Brussels sprouts if you don't really like that. I think frozen peas are cheap, full of protein. I put them in my pasta. I put them on my salads. I'm such a mean mom. My kids call them frozen green popsicles, and now they think they're pretty cool. So however you have to trick your mind into eating it somehow, putting it in soup sometimes is a little more palatable. So that's a great question. There is hope, definitely. Yes. Any other questions? Well, great. Thank you so much for the opportunity.
Okay. Don't forget to check out the raffle items out on the registration table. Also, Rock from the Heart apparel is available for purchase here. And if you're interested in volunteering for a future event, please talk with one of our team members or email us at office@rockfromtheheart.org and let us know what topics you'd like to cover at future symposiums. Okay, I'd like to introduce a survivor. Kathy Jo Peterson. Kathy Jo lost her dad at age 49 to what was assumed to be a heart attack. Because of her obesity and food addiction, she thought she wouldn't live past 50, so she entered a food recovery program and lost 100 pounds. Just as things began looking better, she started having trouble breathing. A CAT scan revealed a narrowed trachea, a 5.2 centimeter aortic aneurysm, and a bicuspid aortic valve. She had immediate trachea surgery and was diagnosed with an autoimmune disease. 5 months later, she had open heart surgery to repair the aortic aneurysm. Kathy Jo and her husband Jerry live in uptown Minneapolis. She'll be 60 this May and believes she now has a chance to live to be at least 85. Please welcome Kathy Jo Peterson.
Hello, and yeah, I'm following the dietitian. I'm Kathy Jo Peterson. I'm a recovered compulsive overeater. I have not had sugar in 10 years, fried foods in 6, alcohol in 6. So you might see me pulling out a little bowl during dinner that has my spinach, etc. in it, because I need to be careful of fats, and I can't have a little bit of sugar. I'm going to say that. And I'm going to say I'm grateful that I have that disease. I also have the trachea disease, which is a rare disease, and the disease I have of heart disease. I'm grateful because my life has become so much more rich. I have met people, I mean, literally today I sat down next to Kim. We met in rehab, and I started crying. How do you put into words the depth of the relationships that we form by living and walking with this, and our surgeons and our cardiologists, who to me are so intimate to me today. My grandparents were dead by age 2. By the time I was 2 years old, I never had grandparents. I know very little about that, but they were gone. My Uncle Eddie died at age 36. And I was told a story that he arrived drunk at my dad's restaurant at 10:30 in the morning in Sioux City, Iowa. And my dad said, "Get the hell out of here." He walked across the street and fell down the steps and died of a heart attack. The minute I found out I had a bicuspid valve and it was a hereditary disease, I looked at my cardiologist, Dr. Fanola, and I said, "When you're dissecting, can it look like you're drunk?" I wonder today if my Uncle Eddie died of an aneurysm, which would have been in 1959. My dad told me my whole life, I'm not going to live very long. He also was a compulsive overeater that weighed about 350 pounds. He smoked 3 packs of cigarettes a day, and he died when he was 49 of a heart attack. The weekend that he died, he was puking blood. I asked Dr. Fanola when I was stopped in my tracks with my diagnosis and said, "Do you puke blood when you dissect?" And she said, "You can." So they did not do an autopsy on my dad. I don't know. But right before my dad died, he said, "Take care of your health, honey." And at that time, I was going to Overeaters Anonymous, and I was sugar-free. And I decided I didn't need to go there anymore. And I proceeded to leave, and within 3 days, I was eating with a vengeance. And I lived the next 22 years over 300 pounds. And I had a car accident in 2011, and I was at a bottom. And somehow or another, I ended up in treatment, which I needed in order to get separated from compulsive overeating. And I began to lose weight, and I began to feel good. And I was literally on top of the game, feeling great, happy. And all of a sudden, I lost my job. and my mother-in-law had a stroke. And I did find out after the fact with trachea disease, it can get worse with stress. So here I was with two big stressors, and I was at my mother-in-law's funeral, and my son was following me around. He was 19, saying, "Mom, you sound like Darth Vader." I found out later, he's cute, he's smart, but if you go look up idiopathic subglottic tracheal stenosis, you'll read, you have the Darth Vader voice. So anyway, and then my brother and Jerry's uncle were following me around saying, "Go to a doctor." I also did not go to doctors. I can't remember who said that. I think it was Mike, but I never went to the doctor. I was never sick. But anyway, I went to the doctor, and I failed. I went to the best allergy, asthma, lung doctor. It starts with a K at Abbott. I can't remember his name right now. And he did all these tests on me, and I failed every single one. I couldn't breathe. I was terrible. And he said, "You need to go next door for a CAT scan." And I'm like, "CAT scan?" And as I'm walking through the, whatever you want to call it, skyway of Abbott, over things by McDonald's in Abbott. Anyway, I went, "I have breast cancer." And my whole life I thought, "Oh my gosh, I can't get breast cancer." And I was somebody that got to 300 on organic Cheetos and organic Oreos. And just so you know, they have them. I can tell you the brands if you ever want to know. But I never thought I'm going to die of heart disease, even though Uncle Eddie died of a heart attack. My dad died of a heart attack supposedly, and my uncle and my aunt died of aneurysm, abdominal aneurysms. I thought, I'm going to die of cancer. I was deluded. But anyway, so I had the CAT scan. He called me, that doctor, later that afternoon, and he said, "Kathy Jo, you are a very sick woman. You have two things going on. One, you have idiopathic subglottic tracheal stenosis, which is a narrowing of the trachea. My trachea was the size of a straw. It's supposed to be a garden hose. You're going to be having surgery very soon. And you also have," and I thought to myself, "breast cancer. You also have an aneurysm on your aorta." I was like, "Oh. And you need to see a cardiologist within 3 to 6 months." And I thought, I just have this little dot, and they're going to give me baby aspirin. And then when I'm like 70, they're going to say, "We could do surgery, but you're kind of old now, so maybe you don't want to do it." And I don't understand it all, but I trust my doctors. I believe this process is all about surrender. And I think they needed to make sure that they got my trachea opened and that they could intubate me for surgery, even though they knew it was 5.2, they didn't tell me, because they want to make sure that I stay open, because some people close right away after this trachea surgery. You have to have it repeatedly. I've had it twice, but there are people that have it every 6 weeks. So they probably wanted to make sure I stayed open. So I stayed open, and at that time I did not have health insurance, and I ended up, because I didn't have a job, but I ended up, it cost like $8,000 out of the pocket for that surgery, and I got a new job that had crazy good health insurance. So my open heart surgery ended up costing me $600. And I ended up going into Dr. Fanola, and that's when she told me, after some tests, you have a bicuspid valve, which is hereditary, and you are 5.2, and I had been looking it up and going on all these groups and everything. It said if you're tall, you can wait a little longer. And then she said, "Yeah, but you have a bicuspid valve, which we don't know how long you can wait, so you need to have surgery sooner than later." And I was like, "Okay, well, I have a big event at work in October, and then I'm going on to Christmas vacation for 2 weeks, so can we do this in January?" She said, "You're not going through the holidays with this aneurysm." So she put 2 dates on the table, and one of them was my dad's birthday, October 3rd. He died right before age 50, before his 50th birthday, and I really felt like that was a message from God. And she looked at me and she said, people as healthy as you bounce right back. And I couldn't believe that someone was telling me, the girl that weighed 300 pounds most of her life, that I was going to bounce right back. And I ended up having the surgery, but I know. So I'm on Facebook, and even though Amy mentioned it, I found Amy and Pete. And Pete's the first guy that I met that I could literally, I didn't say it, but you had open heart surgery and you did not die? It was like I wanted to meet somebody. And then Dr. Finola also had me talk to a guy on the phone. His name's Andy, that was in the video. My mom came down to care for me after surgery. My sister flew down before the surgery. My sister-in-law came. My other sister came. I never once had to get an Uber for rehab, which I went because they told me to. I got rides from friends every single time. I was very blessed through the whole process. And then in the back of my mind, I was like, hereditary. My kids, they need to be tested. And I remember I was on the phone with Amy one night, and I said, Charlie's home for President's Day weekend, and he's going to have his test tomorrow to find out if he's bicuspid. And she said, you realize that if they find out he's bicuspid, he might never qualify for life insurance, which, by the way, I don't anymore. It expires in like 2 months, and I can't get life insurance. My ticker might be better than my hubby's back there, but, you know. Anyway, so Amy ended up hooking me up with playing for Patrick, or players for Patrick. This little 14-year-old boy made the winning goal in a hockey tournament. I believe it was in Brainerd. He collapsed, and he died. His aorta ruptured. It did not dissect, it ruptured. And they started this nonprofit, and they show up at hockey tournaments and test athletes. Well, it turned out they do hockey kids under age 18. There was this huge snowstorm. So somehow or another, Amy and I emailed the founders who still were going to do it, and they tested my kids. They could squeeze them in because there was less people there that weekend. And neither of my children are bicuspid, thank God. They double-checked it. After we sat down, the guy that was a retired, I don't know, he read the ultrasounds, is that what it is? I don't even, echoes, whatever. He said, let's just look again. And then he did, and then he came back to the table with a big smile, and he goes, I saw 3 valves. And that was very relieving to hear. Anyway, I never dreamed that I would be able to have a story that's positive to help people with such a hard prognosis. But for anyone that hasn't had surgery, John, you don't know, but your mom was up here earlier. Rosie already talked. But again, Rosie at age 80, not at age 81. Or were you 79? Now you're 80. She doesn't like me adding a year to her age. She had emergency open heart surgery. And she's another miracle in this room. So there's a lot of support out there. And we do this together. And it makes me think of, together our hearts beat as one. Thank you.
Okay, our next survivor, Lauraleen Jordan. In January of 2006, Lauraleen survived an aortic aneurysm that had ruptured the night before her surgery. She feels blessed to be alive. Heart disease runs rampant in her family. Since surviving her own heart issues, she has made it her life's mission to tell her story and helping others become their own health advocate. Laureline moved to the Twin Cities in 2000 and currently lives in Brooklyn Park. Please welcome Laureline Jordan.
I am vertically challenged. But listening to all the stories today and to the physicians, it got me thinking that all of us that are survivors are lucky and blessed. My story started off in 2005. I was at work. I didn't feel well. I went to the, I guess, not quite emergency room, but went to my doctor's office. And then 20 minutes later, I was in an ambulance driving from Bandana Square to United Hospital. And as they were passing by my church, I realized, one, I have no family in Minnesota. Two, nobody knows where the hell I am. And three, I'm in this ambulance. They're giving me nitroglycerin, and my heart is still racing. And I'm like, this is not a good situation. Got me to the hospital, and immediately they're like, oh, you're just stressed, because everything started to calm down. So they released me. I had a friend come pick me up, and I went and sang at a funeral of a friend that dropped dead, shoveling snow. Fast forward, they had me go to my general practitioner, and she started listening. And she said, you have an aneurysm. She said, you have a murmur. And I said, yeah. She's like, do you know what's causing your murmur? I'm like, no, I've had it all my life. Huh. But you don't know what's causing it. I'm like, no clue. She said, oh, okay. So she started this quest to find out what was causing the murmur, because every time I came in to see her, which was every about a month and a half, it would change. And a murmur is supposed to be consistent. Mine was not. So that was one of the triggers. So she started doing all these tests, and it was the final test, which I wasn't gonna do. It was a TEE, transesophageal echocardiogram. I didn't wanna do it, because as soon as she said, they're gonna knock you out, I'm like, She's like, they're gonna take a scope down, She's like, but it'll be, She's like, well, you can have somebody. I'm like, let me call my mama. So I called my mom. I said, she wants me to do this test. I need you to take the train up here, because she's talking about knocking me out. And I don't like anesthesia. She's like, oh, yeah, you're bad with the anesthesia. I'm like, yeah, I need you here. So my mom came up, and we did this last test. And even then, after the test, the cardiologist was like, not quite sure. I think I'm looking at a cyst, but I'm going to get have somebody else take a look at it. And I said, oh, okay. And at that point, I was a regular exerciser. And he's like, yeah, you can go home for Christmas, exercise, do whatever you want to do, da-da-da-da-da. I'm like, oh, okay. Go home to Illinois for Christmas. Next thing I know, I get a call while I'm there from the cardiac surgeon. And I'm like, first of all, who are you? Because this is the different name. Okay, you're who? All right, perfect. And he says, I know what it is. And I'm like, oh, okay. He's like, well, when are you back? I said, I'll be back around the 1st or so. He's like, well, come in on the 3rd and have a consult. I said, okay. So I came in, and the surgeon drew a picture, and he said, you have an aneurysm off your aorta, about the size of a quarter, shaped like a strawberry, about the size of a quarter. And I said, huh? He said, well, you have what we call a sinus valsalva aortic aneurysm. It was right above my valve. And I was like, okay. And then all of a sudden he started talking. Well, we have to do this, and you're gonna have to have open heart surgery. Stop. Open heart surgery? He's like, yes. And I'm like, okay. And so he goes, by that time, I'm just blank. My mom's sitting there writing everything down. And I remember looking at her saying, I did not want to die. And so we're both in the office crying, and I'm like, I don't want to die. And she's like, we're not going to let you die. And I said, okay. For me, because I knew what open heart surgery does to a person, because my father had had a quintuple bypass. His brother had had a quadruple bypass. My grandfather had a massive heart attack at age 45. So heart disease runs in my family. And I had seen it take out a cousin walking down the street of Chicago, drop dead on the street at 35. So I've seen what it has done. I never knew that I might have had something. So the night before my surgery, they had me hooked up. They did which was blessing. They allowed, so going back a little bit, I was at work again. I knew I was supposed to have this surgery. All of a sudden, I didn't feel well. My coworker comes in and she's like, "Your lips are blue." And I'm like, "Oh, I'm fine. But I really don't feel well." She's like, "Yeah, but your lips are blue." I said, "Well, I just called a friend. She's coming to pick me up." She's like, "But your lips are blue." I said, "She's gonna drive me. She's gonna drive me. Don't worry." So she helped me collect my stuff. Walked downstairs. The lady at the receptionist desk, she's like, "You don't look good. Your color's bad." Yeah, I have a friend that's coming to pick me up. No, I'm gonna dial 911. No, my friend's coming to pick me up. So my friend came and picked me up, and we're driving to the hospital. And I'm like, "Oh, I'm feeling a little bit better." She's like, No, you're going to the hospital. I was like, "Okay, but I'm feeling better." She's like, No, you're going to the hospital. So they took me to the hospital, get there. They're about ready to release me. And my friends are like, "No." And they immediately called the cardiac surgeon. And he's like, "Well, if she's there and she says she's not feeling well, we know we have to run a whole bunch of tests. We might as well keep her." So they kept me. They ran the test. It was when they did the angiogram and aortogram that they realized it was leaking. So at the times that I didn't feel well, which had happened over the years, it was mixing oxygenated and non-oxygenated blood. I had 2 different blood pressures in each arm. I can only describe it as I wasn't feeling well. So the night, my parents came up from Illinois. The night before my surgery, all the bells and whistles kept going off all night long. And I just didn't feel well. That's all I could describe it was. I knew something was going on. I just didn't feel well. And Mom's like, "Well, you're just stressed." And so about 3 o'clock in the morning, she climbed into the hospital bed with me. And she's like, "You're going to be okay. You got this surgery coming up. You're just stressed out." I'm like, "Okay, fine." They prep me, take me in for surgery. It takes a little bit longer than they anticipated. Come out. The doctor asked my mom, "Did she not feel well? Was she complaining?" Mom's like, "Yeah, she was complaining all night long. The bells and whistles were going off." He's like, "It had ruptured. She was going into congestive heart failure." He's like, "We got in there in the nick of time to stop it." And so from that point on, I realized, one, I had to be my own health advocate, because I had to find first of all, it took me a while to find a primary physician that listened to me, because I had had several others blow me off. Because it had been in my record all my life that I had a murmur. Nobody took the time to figure out what it was. And what was happening was the murmur was changing because the aneurysm was creating its own flow. And when I went back to my primary care physician, she was like, "I never in a million years would I have guessed that's what it was." And even my dad's cardiologist, because of course they say, "Get a second opinion." And he's like, "Oh yeah, I've seen this, but on a cadaver when we're doing an autopsy." I was like, "Okay." And my mom's like, "So this guy that's doing this surgery," he's like, "Oh, he's the best. He's kind of old, but he's the best." And she's like, "Old? This is my middle child." He's like, No, he'll be good. But if you want to come home, I'll do it." And that was my plan, to come to Illinois to have him do it, but I never made it. And if I would have gotten on that plane, I wouldn't have been here. So for me, having Amy reach out to me was phenomenal for me, because at that point in time, I had not heard of that there were other people that had aortic aneurysms and other people that had gone through, because when I went to cardiac rehab, they're like, "Oh, well, heart attacks and da-da-da." I'm like, that's not what I had. I had an aortic aneurysm, which is different from a heart attack. And just, when Amy reached out to me, I was like, "Oh my God, so sorry, Pete, but oh my God, somebody that's just like me, that went through what I went through." And so having this symposium and meeting people that have gone through what I went through, is encouraging to me. And it's kind of like this, you know, kind of unfortunate but fortunate sisterhood, brotherhood of those of us that have zippers, those of us that have gone through cardiac rehab to know how that feels, those of us that had their elderly parents lap them on a track, and I'm just like, no, they're lapping me, this is not right. And then realizing that when they do crack you open, oh, it impacts everything. So every little sting or a little twist, and you're like, is that something wrong? And just even taking 10 years to realize I'm still living. So it took me 10 years to start telling my story. And I think part of that was the psychological piece. And I think the other part of it was finding out there are other people out there like me, and then having that support to continue to tell my story. So if you take away anything, one, there's always follow your family history because it's there. Two, you gotta be your own health advocate. You have to be. Because if they don't listen to you, find somebody that will. Because it might just save your life. Thank you.
Okay. Next up is Teresa May. Teresa is a professional dancer and was a Radio City Music Hall Rockette for 12 years. She has been on the television show Dancing with the Stars, and she was a Vegas showgirl for 5 years. Teresa was diagnosed with an aortic aneurysm in February 2019 and is under wait and watch. Her father is a survivor. She is a widow and the mother of 2 sets of twins. Come on up, Teresa May.
Hi there. Hope you can all hear me. All right. Thank you to Amy and Pete for inviting me to be part of this community. It's an absolute godsend to be involved with all of you. Amy, I think, actually found me on Aortic Hope on Facebook. I just went back while you were speaking and read my 2019 post where I was absolutely blindsided and didn't know what in the world was happening to my life. And Amy reached out, and it's been incredible to have that kind of support. In fact, Amy and Pete just came to my husband's funeral. He just passed away just before Thanksgiving of a widowmaker heart attack unexpectedly at the age of 43. So living a bit of a crazy life right now. So how do I end up here? What's my story? They kind of just filled you in. I was a professional dancer. I grew up in Minnesota, Larkin dancer, straight out of Maplewood, Minnesota. I moved straight out to LA and New York and chased my dreams as a professional dancer. I lived in Las Vegas for 5 years as a showgirl. I did Radio City Rockettes for 12 years. I did 3 different cruise ships. I even was able to get a college degree through the Radio City Rockettes in pre-medicine and biology, which ends up helping me in this moment, in this situation. And I go on to have a year of medical grad school, which helps me even further, because I had heard of Ehlers-Danlos and of aneurysms, but I am exercising one day in my basement, and I've been feeling a little sick. And I just thought to myself, you know, I'm getting a little dizzy on my bike. So maybe I should go into Woodwinds Hospital and get checked out, walk-in clinic, right? At this point, I have retired from my dance career. I've had 2 sets of spontaneous twins, 2.5 years apart, 4 little girls, all surprises. Isn't that amazing? It's incredible. I love it, but it's, you know, surprise after surprise in my life. But I'm trying to stay very healthy. Being a professional dancer, you want to take care of your body. You care about what you eat. Usually non-smokers, you know, we really try to take care of this instrument that we live in, you know. You know, being a dancer, you care very much about your body. So I'm exercising on my bike, trying to take care of myself after my 2nd set of twins. I'm 1 year postpartum. I'm feeling dizzy, and I'm like, you know, I better just go get checked out. Maybe I have pneumonia or something. I have no idea. So I walk into this walk-in clinic in Woodbury, Woodwinds, you know, And the doctor said, let's just do a chest x-ray. Okay, let's do a chest x-ray. I actually told him, I go, you're probably not going to find anything, and I feel stupid for being here. Honestly, I'm like, I'm so sorry I've wasted your time, but okay, let's get a chest x-ray. On the chest x-ray, I'm sitting down with my doctor. He's like, you don't have pneumonia. Your lungs look very clear. He goes, but I think you're going to need a cardiologist. You have a dilation of less than 50%. And I was like, wait, let me pull out a piece of paper and a pen, because wait, what did you just say? I had understood some medical terms, so I'm like, a dilation of less than 50%. What in the world does that mean? Okay. So I wrote that down. At this point, I don't even have a primary care doctor, and he's telling me I'm going to need a cardiologist. So I drive home, and like I said, I'm very blindsided, and I start reaching out on like Facebook of like, what is this thing? And you start doing the Google thing that everybody does, Dr. Google. And, I'm starting to get panicky. So I immediately reach out to a primary care doctor, and I go see him. So, all right, this is actually 3 years ago, 2 days from now. This is February 27, 2019 this happened. So I'm almost at my 3-year anniversary here of diagnosis, D-Day. By March 1st, I'm sitting down with my primary care doctor, telling him I need to get checked out. And he goes, you're probably okay. I highly doubt that you have anything to worry about. You've been this healthy dancer. You just gave birth to 2 sets of twins, neither of which were C-sections. So you just gave birth to 2 sets of twins in 2.5 years. You've been a dancer your whole life. You're fine. You probably don't even need to really check into it. I'm like, you know what? I'm a little bit of a nag. I have a little inner nag in me, and I'm like, you know what? I need to self-advocate for myself here, and I really feel like I need to go get checked. He's like, okay, let's get you an echo. So I have an echo on March 1st. And wouldn't you know it, on the echo, they see a 4.5 centimeter dilated thoracic aneurysm, ascending, a TAA. And they said, oh, well, it looks like your root is also enlarged at 3.8, and you might have some on your pulmonary artery too. And I'm like, oh my gosh, this is like, okay. So, the primary care doctor is like, wow, I wasn't expecting those results. I was like, yeah, neither was I. So he goes, well, the next thing you need to do is let's get you a cardiologist, and let's get you a CT scan, because that's the gold standard. You really want to go get a CT scan. So that was only 7 days later. I wasn't one to waste any time. For me, having the knowledge is very peaceful. So I just wanted to know as much as I could, as fast as I could. So I got my CT scan, and that absolutely confirmed it. So then, right after that, I kind of went home on the couch. I have 4 little kids. Realize at this point I have 1-year-olds. They just turned 1, and I have 3.5-year-olds. And I absolutely just sat on the couch, I think maybe for 2 months. It was that PTSD moment patients like me get. You're scared to lift your children all of a sudden because you're told you can't lift weights anymore, or your kids. You're scared to vacuum. You're scared to sneeze. We had just had the stomach flu, and I was like, oh my gosh, I just lived through the stomach flu, because that can be kind of forceful. And we had just moved into a new house, and I had lifted my own furniture, had lifted my own landscaping rocks. I've been lifting double strollers. I have 2 sets of little twins. I have double strollers to lift in the car. And all of a sudden I was like, and I just sat on the couch for 2 months. And that's when Dr. Finola enters my life, and she kind of takes me under her wing. And she tells me I need to get up off that couch and get back to exercising, get back on the bike, get back to walking, because that is the best thing for me. And that, I tell you, I sat down on the bike, and I think I cried every time I did it for like the first couple of months, because I felt like I was an absolute crazy person. I've got this problem here, and I'm going to go stress myself out even more by exercising. I mean, that felt like a crazy idea to me. But eventually, it does calm you down. And I learned, I flew down to the John Ritter Foundation in Houston, Texas. And I was part of the exercise aneurysm study. I volunteered to be a part of it because exercise was so important to me, and we didn't know much at that point. So I participated in the exercise study where they had me do bicep curls, and I rode my bike, and we did planks. We did a lot of isometric exercises and wall sits. And I can share with you my data from that exercise study that happened back in 2019. This is June now of 2019. I am a very low blood pressure kind of person. I'm a 90/60 person. But when I did those wall spikes, this isometric exercise, it spiked my blood pressure to 169/111. At that very moment, I knew that I was no longer doing isometric exercises for workouts, and I was going to have to pull back on the high intensity exercising I've been doing, because it seems like all exercise programs nowadays are high intensity, the HIIT workouts. So I pulled it back, and that was like the hardest thing I ever had to do. I loved working out. I loved the endurance and the stamina and the runner's high I would get. And that was like my outlet, having 4 little kids at home all day long. I was a stay-at-home mom, was to work out. So I was suddenly having to pull back on that. And that took a while. But I think that's just part of the process of being in this wait and watch category, is that you just kind of have to process it and get used to it, and eventually it starts to feel okay. It starts to feel better. Dr. Finola is amazing, and she was the one who had me start doing MRIs every 6 months, and now I'm to every year, so I'm doing scans every year. And she does full head-to-toe scans, but I love that because I feel like I'm just being fully cared for and watched. So what else? You know, I just learned that through this diagnosis, I really needed to focus on quality of life. And I just feel incredibly lucky that it was found, because I'd rather be the one, you know, where it was found. I was told then, I went and had a genetic test done. There was absolutely no family history. I had never even really heard of this before. But so I had a genetic test done, and there wasn't much there in my genes. But I said, you know, what do I do next? They said, go ahead and tell your dad, your mom, your sister, tell them they need to go get checked. So my little inner neg comes out again, and I nag my sister, my mom, and my dad. I'm like, you guys better go get checked. This is, you know, quite the deal I'm living right now. And my mom and my sister, you know, they come out pretty normal, but my dad, it turns out he and I share something in common. And so thankfully, he found out about this. It took him about 6 months to go get that first echo. I was like, come on, Dad, go get checked. So, and then after the echo, you know, echoes they can't always show your whole aorta. So you have to go get your CT scan, the gold standard. So we went and had a CT scan within a year after that, and we found out it was like a 5.3-ish or something. Fast forward a little while later, maybe 9 months later, and he passes out at home. And you took an ambulance to the ER, correct, I think? Something like that. And it turns out on his next CT scan, he had grown. He grew to a 5'5". So he had open heart surgery just this last year in 2021. And I'm so very thankful for my inner nag bugging him so that he would get checked. And I'm thankful that I found out, even though it felt like the most devastating moment of my entire life. I thought my life was over. It turns out we are actually just starting to live, really. Like, here we are, a part of this amazing community. So I don't know if my dad wants to come up and speak after me about some of his experiences, but I just want to reiterate that, you know, there's vitality in movement, and we all got to get up off the couch and keep moving and keep living and focus on the quality of life and just consider ourselves incredibly lucky to be here. I'm starting to call myself the lottery winner. I mean, like, how many crazy moments have I had in my life in the last couple of years? But it's absolutely true. I just feel like so lucky to be standing here before you. So thank you so very much for listening to me. And so I didn't warm up my kicks, but all right. Does Dad have something to share? Do you have something to share about your open heart surgery?
Previous life, she was probably a chihuahua or a pocket gopher or something. Because she likes to dig and just keep on digging. She likes to dig and keep on digging until, and thankfully for me, she dug and kept on me until I finally got my check, and everything turned out very well. As a matter of fact, for those of you who have not had surgery, I had a very good experience. I had mine down in St. Luke's, Aurora in Milwaukee. And sounds like we have very capable people here as well. And you're in good hands. The team that took care of me, from the doctors and the nurses and the PAs, seems like we talked to PAs a lot in this whole process. And they were always really, really good, very informative and knowledgeable. The recovery was okay. It was fine. I had virtually no pain, very comfortable. I'm still lazy. I'm not exercising as much as I should, but trying to keep the weight off and going back to my treadmill and just hoping for the best. But I plan on being around another 25 years. Oh, I got that cow valve too, that thing that somebody was talking about. So, and that seems to be working just fine. Moo.
Well, that does conclude the speaker portion. I guess we're on to the question and answer session. How do we want to run this, Amy? Do we? There you go.
Oh, there you are. Question for Ben. Yeah, right there is great. Is your data on incidental CT findings of aortic disease being published?
Yes, the data that we have is currently, we're writing it up. Just that little bit of data is, you have to go through this whole litany of things, and 1,500 patients is quite a bit to acquire. So yes, we are. Is there a follow-up to that? Sorry, for me? Okay, I'm sorry. I'll give you the microphone back then.
It's like, okay. How do cardiac calcium scans factor into congenital aortic valve-like BAV and associated dilation? Sure, if you want to answer it, and there's a follow-up to that. Anybody else want to answer it? I don't know where everybody's sitting.
I'm reading. How do calcium scores against factor in the BAV and association dilation? Let's just take it real simple. So the calcium scoring scans have become very, very good. So they can see aortic aneurysms, they see calcium, and they actually can pick up some abnormalities of solid organ tumors and things like that. So yes, in terms of the specific of bicuspid aortic valve dilation, it's any dilation of the aorta they'll see, because they have the comparison to, they can measure the size, so you'll see it.
So the follow-up is, does everyone with a bicuspid valve and dilation on echo that isn't yet defined as an aneurysm need a CT or MRI to get the numbers?
Yes.
Okay, that's great. Who, what, and where are efforts made to understand these concerns specifically in women? I guess these are concerns about
So we don't split hairs. We don't care what X, Y is not an issue. This is really families. So take a step back. It's not just the women, it's the families. So as you guys elucidated very nicely, it runs in families. So the issue in women that I mentioned, I don't know. Oh, no, I didn't mention it up there, but it has been known that women tend to be more stoic, tolerate pain better than men, and I know, shocking, right? And will present for emergency medical care later, which in this case will lead to increased death. So it was never understood why men will have dissections and aneurysms 2 to 1 compared to women, but women will die equally or more frequently than men. And the answer is that women sit at home and be like, oh, I'm fine. The grandmothers, oh, I'm fine. Let me just get, I'm fine. They're not fine until they're like dying, and then they come in and then it's too late and it's a disaster. So there's no men-women issue. It's just everybody has to get checked out on the family and go like that.
these are all for you. Okay, what complications may a 2-vessel thoracic aortic arch have in the future?
I have no idea what that is. As defined, like that, but I'm assuming that the person who asked was told that normal people have 3 vessels, there are some have more, and they have 2. Nothing is the simple answer. There is a loose association with that and aneurysms, but I don't think we know that yet. So it actually makes surgery a lot easier, so thanks for that, for having that, in case you come to surgery. But I don't think it's any major specific thing that I know of. Okay, excellent. You're doing great, Karen.
Thanks, so are you.
Supporting
So are you, Ben. Okay. Why is an increased heart rate present for months after aortic or other heart surgeries in this person specifically, in 30-some-year-old patients, even on beta blockers?
So the simple answer is you're not on enough beta blockers. The second answer is because you probably were incredibly stressed out from the experience, which then led to you having a post-experience level of anxiety and that sort of thing. And the other possibility is you have a native arrhythmia that needs to be addressed and that you need to be on more beta blockers. There's about 1,000 different answers. Those are just the top few. So as with everything, we're not here to diagnose. Please see your doctor.
How likely is it that Eliquis will be approved for patients with a mechanical aortic valve?
Now that's a good question. So the Onyx valve, which was shown in Dr. I forget his name, nice guy talk, but which I liked a lot. I'm glad I wasn't close to him because he seemed much smarter than me. The Onyx valve, which is the most recent of the mechanical valves, was designed incredibly well and seems to be less thrombogenic than the other valves, the other metal valves. That valve is currently in a trial with, not with Eliquis, but I think with Xarelto. I'm not sure which it's with, but because it's all closed. But that trial is looking at it to see whether people can take it. My guess is that trial is going to be successful, would be my guess. The valve has already been rated for an INR of 1.5, which anybody who's on Coumadin or remembers being on Coumadin, normal is 1, international normalized ratio is 1. If you're on Coumadin, you can go higher than that, so 1.5, 2 or whatever. So the fact that it was already downgraded means that it's probably going to be a successful trial. Sometime in the next 5 years would be my guess, but it's not going to be the other valves. It's going to be just the Onyx valve. Which valve do you have? That's all right. It's all right. You'll be fine. Coumadin works. It's been around for a long, long time. It works. It's very effective.
As someone that had an emergency type A and has been living with a type B and a strong history of dissection, how do you find a balance in mental health with long-term stress?
That's for you. That's your question.
Well, as somebody who has a type A and a type B dissection, with no history of dissection but history of aneurysms in my family, the easiest way to find that balance of mental health and reducing the stress is to be part of a support group in an organization. It really is the easiest and quickest way because you have an opportunity to meet other like-minded individuals, people, as we talked about, who can validate your experiences. And as we were just saying here at the table, it makes it okay to experience your emotions. You're given permission to say, we can laugh at our situation as Mike did such a great job, or we can become emotional over a situation. And when you are part of a support group, they often bring in speakers that can teach you the grounding techniques, which are really very simple, and I'm sure we can all Google everything these days, but that would be the way I would say. And then, of course, you can always look for a therapist as well. Okay. God.
So the issue of therapy, the issue of being part of a support group is very important. No question about it. I think that these organizations, and I take them as a whole, really do more to help you than probably anything else that you can do. Because, as you said, you had heart disease and you survived. It's like hard to call the people that don't, but obviously, having the conversation. Having the conversation with somebody who has gone through a like experience, shared experiences are actually the #1 thing, whether, your shared experience of trauma and torture as a child, against your parents, or your shared experience in camp, shared experience in life, jobs, and this. Finding people across the country and across the world that have had these shared experiences is so incredibly important. But as our psychiatrist, Dr. Schwartz, will tell you, it's incredibly important for you to fold in a professional person. And when I say a professional person, I mean a psychiatrist. Because people who are now crossing over the line from being able to tolerate and deal with their stress to not being able to tolerate it and needing some medical, meaning medicine support in order to get themselves back, need to talk to somebody. You can't just, listen, marijuana and CBD and all this stuff and alcohol, it's all available and everybody uses it to some degree to help with their anxiety. It is not the best treatment, clearly. So having a psychiatrist part of your team, your own personal team, is incredibly important. And talking about the fact that anxiety and depression and all these other things run in your family is as important as these types of things. So just talk to people. You don't have to be honest with me. Just be honest with your family about this stuff.
Should my BP be monitored differently after aortic dissection?
Differently than what? I mean, there was a great talk, and I've talked about this. I talked about it on the thing. There's a website called validatebp.org. Okay, so these are some important things. Validatebp.org. You can write that down. I think that's what it was. This is an organization of volunteers, physicians who get together and screen blood pressure, home blood pressure monitoring systems, as cheap or expensive as they want, that they work. And there's a bunch of them on the website. I'm not going to tell you what to get or what not to get, but just get one that works. And then they talk to you about taking your blood pressure, which is, Karen, going and sitting for 5 minutes by the clock, calmly and peacefully, before taking your blood pressure. Taking 3 blood pressures in the arm that you know it's the highest if you have a differential, and relaxing your arm and being in a sitting or lying down position 3 times in a row, and doing the same thing at night. And you actually should take it twice a day at the exact same time, take your medicine at the same time. And those are the numbers you should bring to your physician to check. I was doing it wrong and giving people the wrong advice, and I was told to stop doing that, and now I tell people the right answer. So I've been schooled, so I now get to teach you guys.
Okay, this individual's dissection happened at 45 years old, and the question is, if somebody has a job that's really stressful, and now they're trying to live with the after effects of having a dissection, should they consider maybe changing their career, changing their job to reduce stress?
So working and being a functional member of society is by far probably one of the greatest things you can do with your life. Giving back in some sort of way with your career is a great thing to do. If you, and I've had, construction workers and people that lift really big, heavy things come in with dissections, and they have to change their careers. But stress is a relative concept, right? Stress is something that you lump on yourself based on something that someone has told you you need to do. There are people that do the same job that you were doing that you thought was so stressful, and they don't seem to have any stress at all. And we hate those people. We hate them with all of our soul because somehow they seem to be going through life easier than us. But the truth is that there's a reason that their situation is less stressful, and if you can figure that out, you can do your job just as well as you were doing it before with a less stressful approach. Everybody says, how do I do my job? And my friend, who does not do what I do, says, how do you deal with that? All the people, people die and people get sick. I'm like, this happens whether I'm in the hospital or not. I'm not causing them. It's not causation. I'm not that powerful, So I'm just in there trying to help. I'm doing the best I can. So he's like, oh, that's an interesting perspective. I'm like, how else would you think about it? And in his job, he was like taking on all the stuff, and actually just those words helped him to figure it out. So again, psychiatrists and therapists and eating the right food. I love that talk, by the way. That talk was awesome. There's so much depth to that conversation. It's like, it's really phenomenal. But a emotionally stressful job as compared to a physically stressful job, I think you should figure out how to navigate the stress versus change your career, because you just invested a tremendous amount of time, right? You're 40-something, that means you invested a lot of years. I wouldn't just drop it for this. I would figure out how to do it better.
If you had a family member who didn't fare so well in a procedure or in surgery related to aortic disease, what would be some advice you can tell somebody, or really anybody, of the best ways they can prepare before any procedure, any surgery, any intervention? How can they best prepare themselves?
Yeah, it's amazing. Anybody in the room? There's somebody in the room, right? Somebody died. Somebody in the room lost a family member. I remember the conversation. You did, yeah. It's brutal. We hear all the time, you know, I didn't want to come to the hospital because my family member died in that hospital. But that's because they never moved, so the family grew up in Brooklyn, and this is the hospital they go to. Every family member probably died at that hospital, you know. And so they're like, you know, they're hospital averse. It's not the hospital, it's not the situation. It's figuring out what you need. I think you said it very well about your dad. You know, there are people that don't want to know anything, right? They don't want to know anything, and there's other people that want to know everything, every little detail about it. I don't know the answer in terms of how to prepare yourself very well. You will. I think you should, yeah.
I think number one is talking to people that have success stories, even if they're hard. You can do research, you can do too much research, and surrounding yourself with people that are gonna help you keep positive. Even if it's gonna be bad, it's not gonna do you any good to worry about it or be negative going in. It's not gonna make it do better. It actually might make it worse. So Amy, a few times on the phone to me, said, get off the internet, go hang out with your family, or something like that to me. So, and the other thing I didn't say earlier, which I wish I would have, so I will now, is when I got the diagnosis, I was really mad at God. I was like, I worked so hard to get healthy, and you give me just, you know, 3 diseases, because I was diagnosed with basal cell cancer surgery, and I've had 3 surgeries for that since open heart too. So I never had surgery before except C-sections, and now I've had like 8 or 9. But just, there were people I talked to that were, I mean, they told me, I know you said therapy, counseling, but it was sort of like, are you on antidepressants? Are you on anxiety medications? You better get them from your doctor now. And I was like, really? Because this is going to be the most worst, horrible thing in the whole world, like going into the Vietnam bombs or something. And it is bad, I mean, scary, but it's, I mean, look at Mike. I'm mad at Mike because he barely talked today. How many heart surgeries have you had?
6 heart vascular surgeries in the last 6 years.
Yeah, 6 and 6 years. And that guy smiles brightly more than most people I know. Yeah, I mean, Mike, if there's time during dinner, Mike better get on the microphone again. But anyway, I was so mad at God. And I have this crazy, crazy cousin, and I was complaining, saying, why'd God do this to me? And she said, God's been preparing you for this your whole life. So if I would have had an extra 100 pounds on me when I got on that table, I don't know if I'd be here today. And so preparing yourself also to, like Teresa, get on the treadmill. And I'm back on the treadmill. I quit after rehab. I quit. And finally decided I'm going to get back on, and I have a sponsor in Overeaters Anonymous who had a few heart attacks, and she's under 50. And I said to her, I'm going to get on my treadmill 20 minutes a day. She goes, where'd you come up with that? What's your cardiologist say? And I'm like, I called rehab. They said 30 minutes a day, damn it. So Jerry, am I doing it? I'm doing it. And I'm really happy it has solitary on it, the one I bought. So anyway, thanks.
Did anybody else have any other questions? Want to raise a hand? I have a quick question about the nutrition aspect. So I was Googling a lot of the sites you had up, and I'll be honest, I shut them all down because it just seemed way overwhelming to make that kind of change. I am a meat eater. I don't eat a lot of red meat. I will eat some fish. I can't do all the vegetables and fruits, Crohn's disease, a lot of background, but how does somebody who wants to make a change, how do you even begin? I mean, what would you recommend to do that change? Oh yeah, it would help if I came over to you. I have the mic. It's a long day. It's a long day.
Great. No, this is a great question. So I think those SMART goals, so you don't have to do it all at once. That's my overarching message. Just pick 3 things, whether it's, I'm going to eat some more nuts, I'm going to eat 1 more serving of vegetable, I'm going to try some soy milk, or I've had a patient just do almond milk in their coffee, like just to try, just slow but steady, and pick 1 website to look at. There's a couple resources, and my husband isn't vegan or vegetarian. Eating meat isn't evil or bad. I really don't think of foods as good or bad. I'm raising 3 little girls, so really that relationship with food is so complex. But talking about, they do studies where they've got these cells and they put different foods on it, and the cells either grow healthy or they die. And so thinking about that food we put in fuels that good stuff or that, stuff that isn't as good to grow in our bodies too. I think these personal experiences, have made me passionate about it. But I think hearing from patients how other things have improved too, so maybe you don't have a cholesterol problem or whatnot, but just, I have a daughter who was on 3 different heartburn medications, and she had 2 endoscopies in elementary school. They put a little attached sensor in her esophagus, and she had over 300 episodes of regurgitation in 3rd grade. And they took a little, and I'm vegetarian, so I was shoving milk and yogurt and string cheese, hoping that she's getting enough calcium and protein. And within 3 days of cutting out dairy, the endoscopy showed she was lactose intolerant. She got off all her medications. And she went to state and track as a 7th grader. She's very strong without eating meat, but that doesn't work for everyone. I have another daughter who loves bacon from my mom. And so it's whatever works for you, and what might work to cut out milk for some person. Some people might not work for others, but you do want to make it sustainable. Do something good about 90% of the time. Don't worry about perfection, that 10% of the time. So, even just, I talked to a patient today, so I do these visits now with any patient from the community or who's referred from primary care, and we really talk about what's manageable. Maybe for people who don't like vegetables, putting, a little bit of spinach in a smoothie. Surprisingly, it doesn't taste like spinach. It makes it really frothy and gives it kind of a fun texture, or a little bit of avocado to make it creamy. What are ways you can try? And give it a week or 2 or 3, and if you don't like it, try something else. There's no exact science to it. And yeah, those resources, I'll look at the Whova app, see if I can answer some of those too, but just see what works for you. Does that help answer that?
Does anybody else? Okay. You're just making me go back and forth, left to right. I am, there it is. It works off my bag of smart popcorn.
Okay, this is for you again here. I'm on blood thinners, and I don't like vegetables, especially green ones. So I use that as an excuse to not eat any vegetables. And my brain is fine with that, but I know that's wrong. So since you're real good at this, what are 2 green vegetables I should start eating next week to try and force myself into a life of more vegetables without sending my INR through a dangerous thing? And checking my INR is not too hard. It's half a mile away. I have an open invitation.
Oh, this is a good question. So we worry a little bit less about it. Some patients who are now on the Eliquis or Xarelto, but my easy out would be, it doesn't have to be green. There's so many vegetables that have great nutrition. There's corn isn't the evil, carrots. There's things that are starchy. Potatoes are a vegetable. That's okay. Sweet potatoes, those sorts of things. And so, is not. No, I don't think so. I get those ads, on Facebook that say corn is what's causing all our problems. If it's a whole food, I'm not worried about. If it's in corn pops or things like that, that might be a little bit different. Yes, corn chips. But yeah, if you don't enjoy green vegetables, and I do have some concerns when I give this talk for patients who are on warfarin, so I have a relationship with the dietitian at the Hy-Vee down the street. And we have talked about when people are on Coumadin, or they have diabetes, or they have diverticulosis, like, let's make sure we're all on the same page, so we're not saying, eat all these seeds, and then they get a stomachache. So I think if you're worried about the green things in your diet, there's so many other vegetables, you know, red peppers, or yellow peppers instead of green ones, you know, or that sort of thing. Are there any vegetables that aren't green that you like, or that you've tried? Sure. That's hard to want to rock the boat. Yeah, and it's really a consistent amount a week. So I have patients who are on Coumadin who eat salads, you know, when they work 3 days a week, and as long as it stays the same per week, we don't see that variation in the INR as much as someone who goes on vacation and eats, you know, a bunch of green things, and then the next week they come back and don't eat any. So it's a consistent amount each week. And then if you are saying, I love salad, I really miss it, then I will tell people, okay, just go get your INR check sooner than they think, you know, and let them know, and we'll, through electronic medical records, can kind of communicate with the Coumadin clinic and make sure that we're keeping a close eye on things. So at the beginning of the change, you do want to check it a little more frequently. Yeah, but then once it's steady and you find your goal, that should stay pretty stable. But that's a great question. Yeah, any others? Okay, great.
My joke is Pete could look at iceberg lettuce and have his INR go up. So, well, we're early and there's nothing wrong with that. I mean, should we give a hand for everybody in this room today? My goodness. I'm just, every year I think is like, oh, am I going to be able to pull this off again? Am I going to be able to pull this off virtually? So I thank each and every one of you who took time out of your day to be here. What we'll do now is we'll move out into the foyer when they'll reset for dinner. I did tell them since we're early to try to push up the dinner a little bit. So they'll open up the bar so you can have a drink. And we have some people, I mean, this is the time that I think after the speakers that I love the most is getting to know each and every one of you. But when you see me running around like this, it's because, of course, everybody always wants to talk to me and Pete because we're the people. But talk to each other. We love to talk to you. But I mean, look at this community, the stories, the camaraderie. I mean, you look at somebody from New York. Raise your hand if you're from Minnesota. Raise your hand if you're not from Minnesota. You traveled in for this. I mean, isn't that amazing that people are willing to come this far in February? So on that note, one final thanks. I could say it 100 times. This is the long Minnesota goodbye of presentations of symposiums. So let's go out to the foyer and enjoy some time together. And then those that are staying for dinner, when you come back in, we'll hand you a card that has your dinner options. So socialize. They'll let us know when they're reset, and we'll have dinner.
Never thought that we'd go this far. Don't stop now. Reaching for a distant star. Don't stop now. Isn't it strange how we're safe at home? So that I'm counting days until the second come. If you're gonna make a change, you have to let me know. Turn this shit around, start at top the lungs. It's all you need to do.
Hello, am I on? Can we kill the background music? There we go. Welcome back, everybody. We do have a dinner speaker scheduled, if I could have your attention. Jennifer Fernjack. Jennifer Fernjack was raised in Cloquet, Minnesota, currently resides in Spring Park, Minnesota. She received her BA degree from the University of Minnesota Duluth and an MBA from the University of St. Thomas. Through a medical scare in 2016, she learned that things such as music, gratitude, laughter, pets, and acts of kindness can actually lower stress hormones and influence the feel-good chemicals of the brain for patients, survivors, and caregivers. Her messages of hope and emotional grit have been heard at places such as the Mayo Clinic, Health Partners Neuroscience Center, and the University of Minnesota. They can also be found in her book, Greater Than, The Power and Strength of Emotional Grit. Please welcome Jennifer Fernjack.
Thanks, Mike. Okay, can everybody hear me okay? Is this an okay height for the mic? So tonight I want to talk about how music is so much more than entertainment. Well, of course, the entertainment value carries a lot of weight too. I know even just being at the Fargo event a few weeks ago, just being at the concert and hearing Pete and his band perform, and Night Ranger, of course, as well, it was just, to me, a sense of normalcy, especially after 2 years during the pandemic of not even going to a concert in person. So the music had a great way of uniting the group. And of course, tomorrow night at the Grand Funk Railroad concert, it'll be the same kind of a thing. But I want to call out the fact that music can actually affect people physically. It's something that can actually not only affect you physically, but also emotionally and cognitively, as I'll show you tonight. So there are definitely some health benefits to it. Now, the thing about music, though, is that even though it can lower your stress hormones, such as cortisol, and increase the actual feel-good chemicals of the brain, such as dopamine or serotonin, music is also very subjective. So one person's good music is somebody else's noise. And so I know that for me, based on when I went to high school, I liked old school hip hop bands. I liked what I called hair bands. so whether it was LL Cool J or Def Leppard and Bon Jovi or whatever, yeah, I kind of liked it all, you know. So so it's pretty amazing how that can affect things. And I know that sometimes different hospitals will actually play someone's favorite type of music, whether in an MRI machine or perhaps a radiation machine or some other kind of a test. And the favorite type of music is a great way to try to appease somebody as they're in kind of an ominous state. But by actually playing their favorite songs, that's a whole other level. And a good example of that would be, say for example, you're in a hospital room and you don't have a tablet. Like there's no iPad, you don't have a smartphone. So all you can do is just watch TV on the TV that's in the room. Well, if it's a double room where you're sharing it with a stranger and the two of you are having to share that one TV, the person might think, well, I heard that you liked crime shows and I'm watching CSI, isn't that okay? And you might think, well, I'm more into Law and Order. Well, it's still a crime show, but it's not your favorite show. And the same thing happens with music. You want the actual stimulus to have a saliency to it, which means it's relevant to you and carries some meaning. I know that with music, anything that can actually remind you of maybe your time in high school or your first kiss or your first time in your brand new car, that kind of music can have some meaning for you. So it doesn't matter who you are or where you're from, music can have that kind of an effect on you. I know there are studies that show that premature babies in NICU units could actually have their heart rates lowered when they hear lullabies. They can also have their pain perception affected in a positive way by lullabies. And of course, having their feelings of anxiety reduced as well. So it's pretty cool how they can actually just kind of soothe little infants. As far as adults go, I've also read stories about people, for example, who have Parkinson's disease. Oftentimes those people will shake as they walk, and it's kind of hard to have a normal gait. But if they hear music that's relevant to them, they're actually more apt to dance and not be shaking because those dopamine levels are increasing. So it's interesting how even people with Parkinson's disease, it can make a difference in how they dance versus how they walk. And then regarding dementia, I know that years ago my mom worked in a nursing home up in Duluth, so up by Lake Superior, and there were a number of patients who had Alzheimer's where they seemed rather agitated and kind of withdrawn and they just didn't want to really be around anybody. But yet my mom, as the nurse, had to get them to take their prescribed medications. And so she thought, well, you know, if someone seems kind of agitated, how can I get them to take their medications? Well, my mom, now keep in mind, this is before she had access to the internet. This is like back in the 1980s, you know, so she learned to wing it, and she learned just from her colleagues as well, the importance of bringing a tape player to work. So she had a tape player, and she put a tape in there whenever she wanted to get those people to take their medications. And of course, it was music that was relevant to them. So it could be, for example, like big band era music, or maybe a little bit of Bing Crosby, or anybody else who's of that era singing, and that way those people were more apt to relax because those stress hormones are being reduced and the feel-good chemicals of the brain were increasing. So it was pretty great how she was able to connect with them via their favorite kinds of music. So as I mentioned, music can also affect people cognitively. And there was a study in England a number of years ago where someone went to a supermarket and they had bottles of French wine and bottles of German wine. There were the same number of bottles for each kind of wine. And in addition to having the same number of bottles, they were also similar in price, or they were similar in taste, whether it was the dryness or the sweetness of the wine. So they tried to have things equal in that regard. Well, the one thing that was different was the music that was playing. Every other day, the people who were conducting the study would play German music, and on the opposite days, play the French music. Well, the interesting thing about all this is that depending on what kind of music was playing, it made a difference in the kind of wine that someone would buy. People were much more apt to actually buy French wine the day that the French music was playing, and of course the German wine on the opposite days. And when asked later if they knew that what kind of music was playing and if it had any kind of an influence on their purchase, people were like, well, what do you mean? Like, I don't know. Like they weren't aware of the fact that the music actually subconsciously made a difference in what they were doing. The same thing can be said just for anybody going into a supermarket in general. Whether you're going to Byerly's or Cub Foods or wherever, more often than not, supermarkets oftentimes have really soothing music playing as you're pushing your cart down the aisles. And that's because they want you to actually pay attention to the different labels that are on the food packaging. Whereas if the music had a really upbeat tempo, people are more apt to just push their cart and kind of be in a hurry and just get whatever they think they want and not buy the additional items. So again, it can affect you cognitively. So I've learned over the last few years that the actual health benefits of music are also being recognized at a community level. I know I've traveled a fair amount for work around the country, and I've noticed at airports. As a matter of fact, this picture on the right side of the screen is a sign at the Minneapolis airport where they're literally asking people in the luggage claim area to play their baby grand piano. That's right there. And I've heard people playing the piano for others while they're waiting for their luggage to come in. I've also seen such pianos at the Detroit airport, New Orleans, Charleston, different places. Also on the left side of the screen here, you can see the piano that I took a picture of at Abbott Northwestern Hospital here in Minneapolis, where volunteers will play that for other people. And how many of you ever shop at Menards, or whoever have shopped at Menards? Well, there's actually a Menards on 394, which is outside Minneapolis, that at the top of the escalator, as you're shopping for PVC pipe or 2x4s or whatever, they have a baby grand piano. And they have people purposely playing the piano for others to have a more relaxing experience. So that the actual benefits of having music playing are also recognized at this community level. So it's pretty interesting. So music can help not only patients at a hospital, but also survivors and caregivers. And some of you might be wondering, well, Jennifer, how do you happen to know these things about music? Did you just do research on your own? And more importantly, how could they possibly help you? Well, I can speak to these things firsthand. And that's because this picture that you're seeing of somebody who's laying on a hospital bed, waiting to go into an MRI machine with an IV in their arm of dye, that's me. And this happened back in 2016 after I had an eye exam, as I do every year to get my contact prescription renewed. At the time of the exam, my eye doctor said to me, you know, Jennifer, I'm acting on a hunch, but for the second year in a row, you didn't do as well in your peripheral vision exam. I'd like you to see a specialist. Okay, I wasn't worried about it. I couldn't feel anything that was possibly wrong. So I went to the specialist, and then he in turn ran more tests and took pictures of the backs of my eyes. He then said, you know, Jennifer, I'm acting on a hunch, so that's the second person now who's acting on a hunch. And he said, I think something might be pushing on your optic nerve. I'd like you to have an MRI. So I did just that the Friday of Memorial Day weekend. And again, this is in 2016. And the very next day, I got a phone call that I never saw coming. It was the eye specialist with the results of the MRI. And he said, "Jennifer, I'm afraid I have some bad news for you. It appears as though you have a brain tumor." My initial thought was that of disbelief because, as I mentioned, I couldn't feel any symptoms of any sort. No headaches, no motor skill problems, no speech impediments, nothing. It was almost like we were talking about a third party. So I got out a pad of paper and a pen, asked lots of questions, took copious notes. But then literally within seconds of getting off the phone, I dropped to my knees and sobbed. My mind went from 0 to 60 in just a few seconds as I thought, am I going to go blind? Am I never going to get married again? Am I going to die? And after about 10 minutes or so of laying on my bedroom floor by myself, just sobbing, I thought to myself, I can't let this consume me. Actually, I won't let it consume me. So I got out my pad of paper and a pen again, and I made a list of reasons why it's positive to have a brain tumor. And that might sound kind of counterintuitive, but for me, it was more a way of trying to get a sense of control and kind of have own my situation rather than having it own me. So the list starts with, maybe I'll lose some weight. And then I wrote, maybe I'll meet a hot single doctor. and then it went on, and it got a little bit more somber as I wrote such things as, good reminder to count blessings, good excuse to reach out to people I haven't seen in a while. And then my list got a little bit too somber for me, so I ended it with good excuse to eat dessert first. And by making this list, I also learned that just like music, that having a heart full of gratitude can also lower stress hormones and actually increase the feel-good chemicals of the brain. So it's pretty interesting how that works. And my tumor is called the meningioma. Basically, it's in the outer lining of the brain that's called the meninges, and mine's between that outer lining, and it's between my optic nerve, my pituitary gland, and my carotid artery. So kind of an ominous spot, about the size of a golf ball. And people had tried to make comments they thought were kind of helpful, but not really helpful. And so I learned that perspective was key in my experience. So for example, some people would say to me, well, Jennifer, if your tumor supposedly grew for decades, possibly even 20, 25 years, don't you wish it was discovered earlier because it would have been smaller? And my response is always no. And then people look surprised. And I'll say, because 20 or 25 years earlier, the technology to treat it would have been different. I'll take today's tumor, And so I learned that perspective was just so important. And even though the tumor wasn't cancerous, the surgeon thankfully had the wisdom to take away half of it, actually extract half of it, but leave the remaining half in my head because of the fact that it's actually encasing the carotid artery, and that it got radiation treatments. And the radiation treatments were hopefully going to kill the cells. And so the first time that I went in to have a radiation treatment done, actually I should backtrack for a second. The night before my surgery, I had been warned ahead of time that I might not come out. I could go into surgery, I could go blind, I could have a blood clot, have a stroke, I could die. And so knowing these things, I thought, out of respect for my family, I wanted to go through my burial wishes with them, and I wanted to go through my health care directive. So I asked my mom, my dad, and my dad's wife to sit at my dining room table with me as I went through the respective items. And even though I knew logically that that was the right thing to do, emotionally it still weighed on my heart. It was kind of like a reverse thing, like I'm the child telling the parents, and so it just seemed kind of surreal. So when we were done, I took a shower, and I thought, okay, with the shower, I want to have it as a moment of just kind of some solitude, but I also wanted to get in a better mood. So I got out my smartphone ahead of time, and I made a list of music on there that's relevant to me. So it was everything from a little bit of Bob Marley's Every Little Thing's Gonna Be All Right, kind of reggae music. I also had some Beatles in there. I had, again, old school hip hop too, and then hair bands as well, and you name it. And the reason why I had the presence of mind to do this is because I've noticed for years that if I go to a health club, more often than not, people are wearing earbuds, whether they're lifting weights or running on a track or doing Nautilus. That's because their music could actually motivate them and be an uplifting experience. And so I thought, well, why not for me? I've also noticed over the years, if I go to a stadium event, like say a Vikings game or a hockey game of some sort, all it takes is a little bit of We Will Rock You by Queen to have thousands of people on their feet and clapping their hands and chanting. And that's the power of music. It's actually increasing those dopamine levels. And what a great way to unite people, too. So as I took that shower, I wasn't in denial of my circumstance, but it put a spring in my step that I had that music playing. Well, and as I mentioned earlier, I had, of course, my radiation treatments, maybe like 5 weeks or so after my surgery ended. And I had stitches at the time from here down to here, and my head was partially shaved. And I remember that when I showed a friend of mine the picture of where the stitches had been removed and my hair was beginning to grow back a little bit, he looked at it and got kind of lightheaded. And he said, "Oh, Jen, no offense, but that picture's kind of creepy." And we laughed about it. And I thought, what a great example of perspective, because what was creepy to him is beautiful to me, because the picture shows that I was healing. So my first day in the radiation lab, I was a little bit intimidated because there was this whole wall full of radiation masks. And I had my own radiation mask made, and it felt like bread dough on my face, because they had to actually fit it to my face and then have the plastic then harden after the fact. And it looks almost like a jousting mask. And it has around the parameter of it little buttons that when I'd be laying on the radiation table, they would actually hit those buttons into the table. That way I couldn't move my head. Like it was just going to be stiff during those radiation sessions. I would also have a Velcro strap around my arms. That way they wouldn't flail off the sides of the table. And so I thought, man, I knew the radiation wouldn't just hit my tumor. It's going to hit whatever's in its way. That radiation is going to hit my carotid artery and my pituitary gland and my optic nerve and all those things where I just don't want it to be. But I knew logically that I had to be there. So I had to figure out the how. So being the consummate extrovert that I am, I asked one of the nurses in the radiation room, I said, "I know you guys have the CD player here with the CDs that you're offering to play for me. And I like pop music, and granted your CDs are pop music, but they're not my favorite songs. So would it be okay if I make a list on my smartphone again?" And I saw that they had a docking station with speakers. That way I could listen to music during each of my 3-minute radiation sessions. And they said, "Oh yeah, go ahead." So that's exactly what I did. And one day in particular, the song of the day was Rapper's Delight by the Sugar Hill Gang. So that song is, I think, maybe from the late 70s, early 80s maybe. Starts out kind of disco-y, and then the guys start rapping over it. I love this song. So the radiation tech's job, if you will, was to get me on the radiation table, get my mask fastened to my face, have that strap around my arms, and then after leaving me, going into an observation room, and of course turning on my music along the way. And then once he gets into the actual observation room, his job then is to look at a whole wall full of computers. There's a window to see me, a microphone to give me any kind of directions or whatever. So before turning on the radiation, over the music and over the microphone, he says, "And today we have a little radiation for the ladies." It was almost like we were at a club, and radiation was on the house. So I thought, what a beautiful experience, because the laughter, the act of kindness, the music, those were all things that helped lower my stress hormones and then, of course, increase my feel-good chemicals of the brain. But they also helped him as a caregiver. I mean, I have an immense amount of respect for people who work in hospitals, especially for him being in a radiation room where nobody wants to be there. Patient after patient who's there might be projecting their frustration onto you as the caregiver, even though it's not fair. It just happens. And so I thought, what a great way to unite us. So now I always tell people, ask your physician ahead of time. If you go in, say you go in for one of your tests for your heart, ask ahead of time, do you have a docking station in there? Or could I bring some earbuds maybe and have a smartphone with my music? Because it can make a huge difference in your experience. So that being said, I'm curious if there are stories out there with you guys right now. Whether it's anybody who's, of course, a surgeon. Now, I should ask you this. Do you listen to any kind of music when you're performing surgery? Anything that? Good for you. Thanks for sharing. Well, and Amy, I think you had mentioned in Fargo that, Pete, weren't you at the hospital when all of a sudden an Elton John song came on, and you were there to have your heart surgery, I think, and the song was like, "Don't Go Breaking My Heart." And so now, if I remember correctly, the song has meaning for you.
Well, this is how it went down. I had my heart surgery. 5 days later, I had to have a pacemaker put in, and I was probably as close to being clinically depressed as possible because I woke up from heart surgery, and they tell me, we got to do some more. It's like, oh, I went way down. Anyway, wait all day for the pacemaker. They wheel me in that room. The team comes in with their goggles and all that stuff. They turn on the music, and it's Elton John, "Don't Go Breaking My Heart." I mean, I wasn't going to get mad, but I was kind of questioning in my head, did they do that on purpose? Anyway, I decided I thought it was funny, and we did it, and I have a lump and it works.
Perfect. Mike? Oh, yeah.
My wife was dropping me off for my first day of 3 months of outpatient therapy after my stroke, and on the radio comes on Kelly Clarkson, "What doesn't kill you makes you strong."
Yeah. Absolutely. Absolutely. Anybody else? Any music stories? Nice. Little Snoop Dogg. All right. Very nice. Nice. Very nice. Now, I'm wondering if anybody else has had this particular experience. Have you ever driven, say, for example, from your office to your house or someplace where it's a familiar route to you, and once you get there, you're like, okay, how did I even get here? Like you don't remember even driving? There's a term for that that's called highway hypnosis. And I was talking to a nurse about that when I was having one of my radiation sessions, because I had told her that the last time I was at the hospital, I was listening to a song where I was actually quizzing myself on the lyrics during my radiation session. That way I would forget where I was and the fact that I had radiation coming in my head. And that's exactly what happened. Like literally when the radiation machine turned off, for a split second I was disappointed because I wanted to finish my song. Okay, I shouldn't want more radiation in my head, but I seriously forgot where I was. And she equated it to highway hypnosis. Music can have that kind of effect if it's a song that has meaning for you. But anybody else before I close things out? Any questions? It could be both. I know one person in particular doesn't always listen to music because her hospital doesn't always offer it. And she mentioned that she's had so many MRIs that she's used to the banging around of the machine around her head. So in her mind, she pretends that she's listening to a symphony. And she'll try to predict, like, there's the snare drum, and there's the bass, and there's the whatever. And really, it's the machine making the noise. But in her mind, she's trying to make music out of it. I also heard a story from someone at a nursing home who had to have a number of MRIs. And she didn't have didn't have music either at her hospital. But she would lay there and sing to herself in her mind songs from when she went to church as a kid. So she would lay there and sing to herself, "Yes, Jesus loves me," and that would help soothe her while she was having her session. So pretty cool stuff. All right, well, thank you everyone for your time. I appreciate it. Thank you.